eat better here.
Yeah.
Put this on library. Well, they gotta save money where they can.
Well, we called Mark. He
Turned it off on Juneteenth and.
I mean, a whole day.
Trying to get you out of your office, they want you in that OR.
Yeah, with the OR having closed the rooms on Juneteenth. Yeah.
Really?
Yeah.
For you guys, they did that?
They just shut down a bunch of rooms the day before. I guess thinking that staff might call in on Juneteenth or whatever, being it was not an official holiday. Yeah, so lots of services that have two rooms had one. So it created bedlam there, which is dated.
See, for us,
Yeah.
it's a government holiday now, so no one showed up anyway, unless you're on call, But it is a little weird, because it's like a Thursday, right?
Right.
Like a day in the middle
Right.
of the.
Right.
Because it's on the backside.
So did they get to pick which chair they want, what kind of chair?
They got you with either a chair or a lamp.
The lamps are a new deal.
I think they're pretty too, I like.
Yeah, I got that instead of an uncomfortable chair.
I don't know, tell us what you really think.
Do what?
I said, tell us what you really think. I was visiting with one of my really good friends this weekend, well, actually, the previous weekend, we had a college school lunch, the LSU baseball game.
Wow, what a game, huh?
It was a fun game, and, he said the kindest thing about you. He had a really good series.
Yeah, I know. Things are so sorted now. I don't hardly see y'all. You're right. Oh my God.
Their day off on the earth. So out of her grandparents' place. I'm like, "Sure, you probably might have gone over the wall." She said, "No, I see that. Wow, that's really
Yeah, we
It's like, I don't know what you're using.
like you can say, I want to, you know.
Oh my
And
God.
I put you there with me in it, and I'm like, like check, kind of, that is, check.
Yes, yes.
We're doing our checkers.
Oh.
I don't use check, because I have something else that ordering sometimes.
Yeah,
And
yeah.
I start my career.
Yeah. I mean, I have used it until the new software doesn't work.
Yeah,
I
this
don't
is,
use it often.
Getting people in the auditorium's half the battle. You good? All right. Good morning, everyone. Welcome to the 52nd Abramson Lectureship and graduation for our chief residents. This is the best day for a chairman, I can tell you. First day of seeing who you get from the match in general, and then the next day is obviously this, when we're sending you on your way. So we really appreciate what you've done for us in the last 5 years, and it's just a start of what you're gonna see today. So we're so happy to have you here. We've got a great Abramson lecturer, Dr. José Guillem, who I'm gonna formally introduce in just a little bit. But as you know, since I've been chair, we've changed this every year a little bit. When COVID was here, we didn't have an invited lecturer, so we kind of did it on our own. I thought it was quite successful. But now we're kind of settling out of where more of a traditional graduation is going to be taking place today. So what we have today is something a little new, is the Jeopardy. It's been so popular at the American College of Surgeons in the grand scheme of things, and also in our local Louisiana chapter. We'll also have 4 great case presentations that we thought we've done pretty well on, and Dr. Guillem is going to respond to those. A couple of them are not colorectal, I'll tell you, but you can punt at any time, and feel free to do that. So we'll do that. I will formally introduce Dr. Guillem in about an hour after the Jeopardy, and also after our 4 presentations, and then he'll give his formal his Abramson lectureship. All right, without further ado, we'll have Dr. Matt Keene, as a 4th-year resident, present one of our oncologic cases, and followed by colorectal shortly thereafter.
So, my name is Matthew Keene with a PGY4s. This is a case that I did with Dr. Zabari, a surgical oncology case. So, disclosures, I have none. In terms of case presentation, this is a 71-year-old male. He had the following history: our typical hypertension, congestive heart failure, chronic kidney disease, hyperlipidemia, and COPD. No previous surgical history. Social history: he had a remote cocaine and heroin usage, and then current tobacco abuse. He smoked for about 40 pack years. And then medications, pretty benign, just some inhalers, statin for his hydralazine for his blood pressure, and then aspirin. So for this patient, this was kind of a diagnosis that he wasn't expecting coming in. He actually presented to the emergency room over at Willis Knight with complaints of worsening bilateral lower extremity pain. He had known peripheral artery disease and was being treated for that on an outpatient basis. When vascular surgery got involved in his care, they wanted a CT of the abdomen and pelvis to assess for aorta-iliac disease that was causing his lower extremity pain. What they got was partially visualized right upper quadrant abdominal mass, and then that was proceeded with an imaging study to reveal the entire mass. So we'll look at those. There's your axials. Should be able to appreciate this mass pretty well. So very large retroperitoneal mass that's engulfing the right kidney. And we'll also look at it in the coronal view next. Here's our coronal view. So you can see a very large, taking up the entire right side of the abdomen, retroperitoneal mass engulfing the right kidney. So this prompted further workup, obviously. We had an IR-guided core needle biopsy, which diagnosed him with a dedifferentiated liposarcoma, preliminary grade of 2 or 3. He received a PET scan, which showed a metabolically active mass in the right perirenal space and the retroperitoneum, which was compatible with the known liposarcoma, but no metabolically active metastatic disease. He also got a nuclear medicine renal perfusion scan because we were going to take the kidney in an en-bloc resection of the mass, and then also had a left heart cath performed because of his history of hypertension, cocaine use, smoking, which did not have any significant coronary disease. So, in terms of what we did for this guy, we had a discussion at our multidisciplinary tumor board, and the thought was that if it was resectable at that time, that we should just perform a resection of the mass. So he was consented for excision of the retroperitoneal mass, possible nephrectomy, and possible adrenalectomy. We did this case open, midline laparotomy, did a right medial visceral rotation of the colon to expose the IVC in the left renal vein. The mass was abutting right next to the left renal vein, so we had to mobilize it medial to lateral off the IVC to expose the right renal vein so that we could transect those with a vascular stapler in order to completely mobilize the mass. So first we identified the right adrenal vein because that was also engulfed along with the mass, identified, ligated, and then used some white vascular staple loads to transect the right renal artery followed by the renal vein, then ligation of the ureter, and we continued the dissection of the mass until it was freed from all surrounding soft tissue. In terms of his postoperative course, he had a lengthy length of stay, total of 16 days. Disposition was ultimately home. Only complication he had while he was in the hospital was worsening renal function. After that nephrectomy, he was already chronic kidney disease stage 3. He progressed to having some hyperkalemia and some metabolic acidosis, and now he's end-stage renal requiring dialysis, but that was discussed with him preoperatively since he was going to be missing that right kidney, that was a possibility. And then his pathology at the end was a grade 2 dedifferentiated liposarcoma adherent to the right kidney and invading the renal sinus. Did not invade the right renal gland, and then we had negative resection margins, and that was our tumor size, 21 by 18 centimeters.
Nice presentation. I'd like to, Dr. Spark, was your faculty? Yes. Dr. Gaston Spark is here today. I'd like him to comment on that. He's one of our biliary surgeon, transplant surgeon, and chief of surgery for us.
Thank you for a nice presentation. I was not aware he's going to present, otherwise I would provide something from the pictures. Really great pictures, and this is a very complicated case in that with multiple comorbid conditions and borderline renal function. I told him that, likely than not, you will require hemodialysis. We discussed and nauseum and conference at the Beta-Pancreatic Radiant Tumor Board, and consensus were they had biopsies already, so we knew what we're dealing with, and they felt if we could be resected, we probably should. And I was not so sure whether or not we actually have to take cable with it or not. From the images, it looked like probably we have. We have to, and as you know, if you restrict cable, especially if you do the renal vein, mean latency is very, very short. It does not last very long at all. Luckily, we were able, actually, it was not invading cable. We were able to save the cable without doing anything with it. So the mask was taken out, and he actually, surprisingly to me, he did better than I anticipated. He met with his family and everyone else because of the commercial condition. He might not survive the operation. We did not have to give him any blood product. But regardless of all of that stuff, his kidney function went down, and he is getting hemodialysis right now twice a week. He's still making urine, so potentially may end up weaning him off. That is not quite certain at this stage. And as you know, resection is the best way of therapy for this kind of lesion. Really not very responsive to chemo, radiation, and fluid swallow that we require for it. As you know, that there is no way for pathologists to look at all these margins, but we did resect it in blood without getting injured.
Yeah, I just applaud Dr. Sabari for a great case. It's one of the things I like about surgical oncology is that every case is different. You know, you have to try to achieve negative margins, which can be challenging in the retroperitoneum with the anatomic limitations. But you have to tailor your resection to what the mass is involved in. And I agree with Dr. Sabari. The best treatment for this type of tumor is a negative margin resection, an R0 resection. And it sounds like he did a great job getting this accomplished.
Any role for adjuvant therapy in this patient?
So chemotherapy is really not very effective for liposarcoma in particular. Patients have definitely been given doxorubicin-based chemo, and ifosfamide is the sort of the standard therapy for sarcomas, which really hasn't been shown to prolong survival. So a complete resection is the best thing.
Yeah, I'd just like to echo the presentation as well as the management. Kudos to the surgeons for some patient selection, for the performance and the outcome. And although I don't deal with recurrent disease, I did come from an institution, Sloan Kettering was very important. You would always emphasize the importance of a negative margin in this disease. So, great outcome. My question related to what I was asking is sort of if you had a slightly different presentation, and let's just say that you thought it was not amenable to an R0 resection preoperatively, are there anything that you could consider offering that would facilitate a negative margin? And any neoadjuvant, current or perhaps coming forward in the future?
I did learn more to address that question, that we do know that these lesions are not radiation sensitive. They are not really responsive to chemotherapy. However, there are some other means and modalities in regard to embolization possible. But again, as you know, that these lesions getting blood supply from all over. Also, I think that I really don't have any other alternative before I dive in and take this lesion. Yesterday, we took 1/2 of this was robot. It didn't involve kidney. It was we managed to do it robotically with an actually good movement. And here, again, you look at it, you know that the lesion is too big. You have to make a decision big enough to remove it. It might as well put it open and facilitate the resection and what have you. But I'm not aware of any other option, to be honest with you.
I agree.
The other comment was made for the learner. I'm sorry, your name again, sir?
Keith response, Matthew.
Keith Matthews, and you're a PGY4. So are there any PGY2s in the room? Oh, good, great. So just to share with them, I guess from your position, you had the backing of a senior, very experienced surgeon there, but if you hadn't, you must have been thinking, at what point are we making this, crossing the bridge? At what point are we burning the bridge? Are we making an irreversible move? Can you comment on that? At what point did you feel, at this point, we got to go forward, or we can step back?
Interruptively, I think that moment where we're just checking out the right renal vein in terms of trying to resect the margin. As soon as you take the adrenal or the right renal, I think that's kind of the moment where you're saying you have to move forward with the resection of the mass. And then it was any interim findings where it was, major vascular structures, it can't be reconstructed, then I would say you would have to abort after that.
The moment of truth is not well described, but it's in every specialty, colorectal, oncologic surgery, transplant. When you get to that point, and it's easy during your training, your first 5 years, those moments of truth come pretty quickly, fairly frequently. How you deal with those moments of truth, am I afraid to continue to move forward? And there's so many things that work through your mind on whether you're going to proceed with an oral section. So, we're going to tell you the guy's finishing. When you get out there, don't hesitate to ask for partners, senior partners. Go back and look at your imaging before the procedure. Feel like you know that and know the point of inflection that you're going to reach in that operating room, especially the pancreatic resection. I hear Terry talk about pancreatic resection and the SMA involved and some of the things that he has to make a decision on whether we proceed large blood loss operation or, do we back out? Any other comments or questions? Yes.
I just want to say that we did a similar case in Honduras last year. Dr. Larry Moore was there also. We did it open, but we did not have the possibility of doing minimally invasive surgery. Went very well, and for the residents, they joined me, and it was a body when we go to these missionary groups. I want to advertise for that. We go again this year in last week of September. Whoever is volunteering, let me know as soon as possible. We'll take you there. We do a lot of surgeries. Yes, I love it. You agree?
Yes. I want to go back. It was a great experience.
Any other comments or questions?
Just a real quick comment on if tumors invading the inferior vena cava below the renal veins, then typically you can resect that with your tumor without too much of a problem. Most patients will tolerate that. I don't typically reconstruct the inferior vena cava in that instance. Just make sure the patient has full vaccine before you
Again, when you're posed with an advanced colon cancer with retroperitoneum, the vascular involved, how early or preoperatively do you get vascular surgery involved? I mean, is there any role in vascular surgery?
Yeah,
that's
right. As I get the vascular colleagues speaking, I was just going to make the point to the learners that this is a key player in your armamentarium, the vascular surgeon. I got to know Greg Kent. I said it to many leadership positions, but when he was a faculty at Cornell, he was my go-to person in terms of vascular. He's an excellent vascular surgeon. And that relationship is important. There was a lot of planning because we didn't have, in Sloan Kettering, we didn't have an in-house vascular department or division, so it was coordinated beforehand. And a number of times it was one of those, I was like, let me know, but I'll have a number ready for you. But depending on the situation, we plan that.
It's interesting that, the papers I see in thoracic literature about superior sulcus tumors and subclavian vein or subclavian artery involvement is a whole different paradigm of an operation. And how many of those people do you truly cure with vascular involvement? Not only in the visceral, but also in the chest. It's not a lot, that's for sure. Dr. King, great job. Questions are vulnerable, but I think you did well. Thank you. There you go. Don't jump up real quick. Dr. Catherine Williams, she was a third-year one, to be a fourth-year resident.
All right, good morning. My name is Catherine Williams. I am a PGY3, and this is a colorectal case. So this patient is a 65-year-old male who initially presented to his PCP with complaints of pelvic pain, constipation, hematuria, and debris in his urine. He has not had a prior colonoscopy for this. His PCP obtained a CT scan which showed a 7.4 centimeter mass in the upper rectum distal sigmoid colon which showed extensive inflammation consistent with some areas of perforation, and there was some gas seen tracking to the lumen of the bladder, consistent with the fistula. So GI in Texas had performed a colonoscopy and noted a nearly obstructing mass at 15 centimeters from the anal verge, but they performed a biopsy and it just showed necrotic tissue. So this is a portion of that CT. You can see the mass and the gas in the bladder. And then a pelvic MRI was also obtained, showing a stage T4B and positive tumor involving about 5 centimeters of the sigmoid colon. There was no sphincter involvement, but there was some suspicious extramesorectal lymph nodes. So in February, the patient underwent a laparoscopic diverting sigmoid colostomy, and he was also evaluated by urology, who did a cystoscopy with a bladder biopsy, and they placed a right ureteral stent. And this biopsy also came back non-diagnostic. But then in March, he had a colonoscopy performed through the colostomy, and this pathology came back as adenocarcinoma. And this picture here is a picture of the mass. It's an antegrade picture, like through the colostomy. So the patient saw oncology, and a PET scan was obtained showing the mass and then involvement of the posterior aspect of the bladder. It showed the fistula again, then also showed some multiple sub-centimeter short axis perirectal, presacral, sigmoid, mesenteric, and inferior mesenteric nodes concerning for local regional metastatic disease, and it also showed a solitary FDG avid hepatic metastasis. He received 6 rounds of neoadjuvant FOLFOX. He didn't receive neoadjuvant radiation. So this is his restaging CT after chemo. You'll see the diverting colostomy and the right ureteral stent, and you'll see that the size of the mass has decreased.
Yeah, but I'm going to get you to hold after this slide at the last, Dr. Guillem, what he thinks about the presentation so far, as far as this patient, what his plan would be.
Great, so in summary, he's had a diverted colostomy for a sigmoid large mass invading the back of the bladder.
Yes, sir.
And he's had, what was the therapy so far? Any chemo radiation?
Was there?
Has he had chemo radiation?
Yes, he had 6 cycles of FOLFOX by this time.
And radiation?
No radiation.
Okay, and how is he doing physically?
So physically, he was doing fine. There was a few months in between finishing chemo and then scheduling surgery. That way he could gain some weight and optimize his nutrition, but fine otherwise.
And what are the urological assessments of the bladder following? Has he been cystoscope?
Yes.
What do they think?
They had seen some abnormalities in the bladder, and they biopsied it, but it just came back as essentially just non-diagnostic.
So they don't think the bladder's involved at this point following the chemotherapy?
No, they so that was a cystoscopy that was done prior. Yeah, prior to the chemo. I'm not sure if there was one done after the chemo.
Yeah, I think the concern with when you've got this T4 disease that's resulting in a fistulization is the involvement of the bladder, the location of the bladder. If it's something located in the dome, perhaps there's an opportunity for doing a resection that would, again, with negative orange, encompass a piece of bladder. But when it's posteriorly, think of the trigon involvement, the ability to reconstruct is going to be limited. And and the risk of having a positive margin. So I think he's looking at it as innovation in my mind.
All right, so he was taken to the OR, placed in lithotomy position, and a lower midline abdominal incision was made, and the peritoneal cavity was accessed. The rectosigmoid mass was identified, and the white line of Tolt was incised to free up the colon. The right and left ureters were identified and protected, and high ligation of the IMA was performed, and then the loop sigmoid colostomy was then taken down, and this was followed by mobilization of the splenic flexure. The sigmoid colon was then transected proximally with a 75 millimeter blue load GIA stapler, and then a partial cystectomy was performed using electrocautery. And after this, the mesorectal dissection was performed, and the distal margin was verified, and then the rectum was transected with the contour stapler. And then urology took part in this operation as well, and they performed the bladder repair at this time. Then the stapled anastomosis using the 29 millimeter EEA stapler was performed, and then urology finished with reimplantation of the right ureter and bilateral ureteral stent placement, and then the abdomen was closed. So post-operatively, he was discharged on post-op day 5 after tolerating a regular diet and having return of bowel function. Pathology showed moderately differentiated adenocarcinoma, T3 with negative margins and lymph nodes. He received 2 additional cycles of Folfox. He refused any further treatment just due to side effects. And a recent PET scan showed that the mass was no longer present, and then all of the mildly hyperdense lymph nodes had resolved, and also interval resolution of the solitary metastasis of the liver. And he's been seen in clinic recently and is doing well.
How far out from the therapy?
From
From the surgery, how far out?
we are 10 months out now at this point.
So it's pretty amazing.
Who's the fact?
Definitely. Okay. So it's pretty amazing, like single therapy, no radiation, just
Yeah.
full funds.
I think you go back to the post-treatment CAT scan and pause it, and you get down to where the stent is and the black.
So this was more of a dome, not posterior ventricle.
Yeah, he had a pretty dramatic response to the full fox. Okay, right about there, you can stop it. So on the initial imaging, it really looked like that right ureteral orifice was going to be involved, and the initial urologist he saw was a community practice urologist who really didn't want anything to do with the case. Luckily, we have a fellowship trained reconstructive urologist here, so I brought the patient over here and had him see the plan for the neoadjuvant treatment was to do chemotherapy only initially, because the urologist was concerned if they radiated this area, then he would not have any chance of salvaging the bladder because it wouldn't heal. So he wanted to do chemotherapy only, and if he did not have a good response, then add radiation therapy. Since he had such good response to the neoadjuvant treatment, then went ahead and did the surgery without radiation. And that right ureter was the distal part of the right ureter, not really the orifice, but the distal part of the right ureter was still pretty scarred there, so we decided to go ahead and resect that, but he was able to save the majority of the bladder and leave up the reconstruction, the reimplantation, and achieve negative margins. So
Pretty remarkable, I must say. The calculation that went into this, because it sort of reminds you, sort of thinking of Clint Eastwood, do you feel lucky or do you feel not, right? So you were banking that this was going to be a negative margin, and you did succeed in that, which is great, but I would think that you might have, in most, two of us probably might have got some pushback from the medical radiation oncologists saying, you know, just stop with chemo alone, why not add radiation? But I think that the concern that we'll do to respect to the urologists about the radiation to it, as we know, if it's proceeded with surgery shortly after the radiation is complete, it's not as bad as if you wait years later. So I think that, you know, the need for radiation probably would have been recommended to most folks, but the fact that didn't get it, it's remarkable that Folfax accomplished as much so, and obviously kudos to your surgical technique to get negative margins. So well done. But that's a surprising approach and successful.
What do you think the possibility that the hepatic lesion could come back, Dr. Jabbar?
Well, I was about to ask you that question, how you need to follow up with this. You know, at least in our literature, we say that these lesions, what we do not see in imaging modalities, call it vanishing liver mets. And we believe that these lesions should be resected, although, as you told us, the chemotherapy did so well with the primary side, perhaps it sterilized the mets as well. But this lesion, for one, if you have elevated CA and now kind of came back to normal, I think that marker should be used. Secondly, I would get MRA looking at the liver for follow-up, because CAT scan may not be very good, especially regular CAT scan. You're not getting dynamic CT with the liver, because that way you'll be able to see. And lastly, during the surgery, were you able to palpate anything there or not? The other question they'll be asking, you're like it or not. In your oral examination, the reverse approach for rectal lesion, as we all know, rectal lesion can be resected, but it is really have a lot of possible complications and what have you. If you have liver lesion, some advocate actually resecting liver lesion, because we believe that people with demise from the liver mets, not from primary side. So because liver resection nowadays, it can be done very safely and easily while you're giving chemoradiation, and then later on you can go to the pelvic lesion or the rectal lesion to resect it. But it should be followed very closely. We don't believe it'd be very unusual to sterilize the primary liver mets. Although, like I said, this is a very unusual case in that primary side responded so well. If there is nothing in the liver with palpation and tumor markers are fine, just close follow-up. Otherwise, you could be resected very safely in the lateral setting.
Well, one of the CDA directed therapy is monitoring that, like you do with testicular cancers. And you have no marker, resolution of recurrence. What do you do? If you do have a marker recurrence, then obviously you look. What would be your mode of radiology? What kind of diagnostic procedures would you do if you saw the CDA come back? Would it just be an MRI, PET scan to reevaluate the elevated CDA?
Probably good quality CT chest abdomen pelvis, and then perhaps a pelvic MRI. But what's really interesting about this case is the uniqueness of its responsiveness just to Folfax, dramatic response. I think it'd be fascinating to see if you had access to the biopsy of the tumor beforehand, some molecular profile. Because these are the exact kind of cases that medical oncologists would love to know if you had a particular report kind of pre-therapy that maybe single agent de-escalation, as opposed to where I'm going for an exoneration, I'm going for the big extensive thing here. You give a single modality and have a very successful story because of the response. But we often don't know that ahead of time. We wish you could tell who's going to respond to just one agent.
Any other questions, comments, Dr. Williams? John, thank you. Russ Williams. Russ is third year, about to be the fourth year. General surgery. Obviously, general surgery.
Good morning, and welcome to Shreveport, Dr. Guillem. My name is Rush Williams. I'm one of the third-year surgery residents, and today I'd like to present an interesting case performed by Dr. Larimore and Dr. Paul on the surgical oncology service, which had a pleasant outcome. Our patient was a 58-year-old female that originally presented to her PCP for management of her hypertension and new onset bright blood per rectum. She was lost to follow-up and presented to our facility for a screening colonoscopy in early 2024. She had a past medical history of hypertension, prediabetes, a surgical history of tonsillectomy and carpal tunnel release. She denied tobacco and drug use and reported using alcohol occasionally. Her family history was notable for multiple sigmoid polyps noted in her mother and sister on their screening colonoscopies. The colonoscopy was performed in early 2024 by our GI services, with findings of hundreds of polyps throughout the colon of various sizes sampled from different portions of the colon, along with an 8-centimeter sigmoid polyp. The sigmoid polyp was removed in block, along with polyps from the rectum, descending, transverse, and ascending colon, as well as the cecum. The pathology revealed tubulovillous adenoma with high-grade dysplasia from the sigmoid polyps and tubulovillous adenoma from the remaining polyps. And this is imaging from the initial colonoscopy, and this is highlighting that 8-centimeter sigmoid mass, as you can see here. And this is from the same colonoscopy. This is showing the proximal rectum and distal sigmoid colon. You can also appreciate the polyp burden here. Due to her severe polyp burden, the patient was scheduled to undergo an EGD with our GI team here, which was performed 2 weeks later with findings of multiple polyps in the cardia, fundus, and the body of the stomach, along with a 4-centimeter polyp that was identified proximal to the ampulla of Vater, along with at least greater than 5 polyps distal to the ampulla of Vater. Biopsies were taken of these duodenal polyps, and the pathology revealed duodenal adenoma with low-grade dysplasia. And here's some imaging from that EGD as well. This highlights that 4-centimeter duodenal polyp. And here you can appreciate the multiple polyps in the body of the stomach that extend along the lesser curvature towards the antrum. The patient was then referred to the colorectal surgery service for concerns for polyposis syndrome. Genetic testing was performed at that time. It was positive for FAP with deletions of axons 9 through 15 in the APC gene. She underwent a flexible sigmoidoscopy to evaluate her rectal polyp burden, which was deemed low, and also underwent a repeat EGD with endoscopic mucosal resection with our GI services. A total abdominal colectomy with ileorectal anastomosis was performed in June of 2024. Her hospital course was uneventful, and she was discharged on postoperative day 5. So this is that same 4-centimeter duodenal polyp right here. This is prior to the EMR, and this is after the resection. So throughout 2024 and into early 2025, she was admitted multiple times, at least 5 times in the hospital for a small bowel obstruction, and they all resolved with NG tube decompression. She was then referred to surgical oncology, giving her FAP diagnosis and concerns for multinodular thyroid goiter. She had bilateral thyroid nodules, which were near 1 centimeter in size. Dr. Larimore performed an FNA in his office, and the results were benign. So Dr. Guillem, I would love to hear your thoughts, given your expertise about this case, a lady with FAP, multiple duodenal polyps, and pathology being low-grade dysplasia.
Oh, a great case, and it's something dear to my heart, polyposis and brain syndrome and things of that sort. And this could be a whole day event, you can imagine a whole week event. There are meetings that discuss this particular topic, so I'll try to just highlight a couple of things. First and foremost, I would say that there have been numerous surgeons that have played significant roles in our understanding of the disease. I'll mention one of them later in my chat today. One that I don't mention, but in some of the Lemuel Herrera, who was a surgical oncologist at the Roswell Park. And Lemuel Herrera, when he was at Roswell Park, and this is for learners, just to point out how important it is, us as surgeons, as clinicians, to be very observant as we go along. And if you see something, as they say at the airport, speak up. Similarly, as a clinician, if you see something, take note of it. And if you happen to just be lucky to be having access to another collaborator, like a geneticist, as Dr. Lemuel Herrera had, he reported, I think it was Sanderson was the geneticist back in like 1985 or 86, in a genetics article, a description of a patient who had Down syndrome. abundance of these extra colonic manifestations of polyposis. And up until that point, there really was no gene for polyposis, but it was that cytogenetic study that pointed out that it was the 5q2122 segment where this was associated with that person. That led some major scientists around the world, in England, Imperial Cancer Research Fund, and people like Vogelstein and people out White in Utah, to identify the APC gene. So it's just, up until that point, nobody knew where to look for the gene because the technology, restriction like polymorphism and other complicated things, you needed a target. It was that person who had Down syndrome and all these abundance of polyposis syndromes that led the scientists to do that. So that would never have happened without Morales' contribution. So it took a surgeon to lead the scientists to identify the gene. So just keep that in mind. We played a part role besides doing great surgery. Yeah, so FAP, I would tell you, despite all the research, there is no current specific genotype-phenotype correlation. It would be ideal to know that a particular APC, and there are upwards of 700, 800 different mutations that can explain in the APC gene what FAP is. But since we don't know which mutation predicts the outcome of the colon or the rectum, we do it by clinical judgment, which was exercised here. And you mentioned the low burden of polyps in the rectal sigmoid, which is you can leave behind the rectum in that case. So total colectomy with rectal anastomosis is considered a very good approach at this point. I think the upper GI, there's things that come to mind. For the years, there was a field back in the 1990s, early 2000s, that studies that demonstrated that all FAP patients with biopsy of normal duodenum, 99% of them had adenomatous findings. So we began to worry, oh my God, it's a matter of time before all our FAP patients go on to get adenocarcinoma in the duodenum. But very few do, and there's Spiegelman criteria that are established as a very good score. But when you have something of that size, the approach that was taken was totally appropriate. The other aspect of this disease, as you know, is a desmoid. So this is a concern. By doing this linear operation, not doing a pouch, there's less likelihood of developing desmoids in the future for this person. Another fascinating aspect of the disease is that when they did back also this procedure, and people had lots of polyps in the rectum before the advent of the J pouch, right? This is the procedure of choice, even if you have a lot of polyps. There was a subset of patients in whom the polyps regressed in the rectum. And I didn't believe that data, but actually that's a patient who I saw that remarkable, and that is a fascinating research question that I would love to have when you folks pursue. What is it about the liver that when you take the colon out and you connect the small bowel to the rectum, those polyps disappear? So great. We could go on for weeks about this stuff, but I would just say, I think the management was done well. Can I ask you a question? How are you going to follow this patient?
So I have a couple more slides, but to get to the point, I think she will need yearly endoscopy through the proctoscopy to view the rectum. She will also need annual bilateral thyroid ultrasound, and then for the gastric polyps that she had, they can be followed on an individual basis over 2 to 3 years.
Do you happen to know what type of thyroid cancer is associated with FAP?
Papillary.
There's a subtype, and it's not a trick question, I always forget it myself. And I've written papers on this, but it's a funny name, and there's a specific type. You might want to look it up because I believe it comes up in the in-service every so often.
So she presented to a surgical oncology clinic, so Dr. Larimore. Her initial Spiegelman score was 8. We discussed surgical management versus the frequent endoscopic surveillance, and at that time she wished to pursue the endoscopic surveillance given the morbidity of a whipple procedure. The EGD was repeated 6 months later, and the findings were notable for multiple duodenal polyps. The GI team quoted that they were hardening the mucosa and were not amenable to any more resection. Attending actually called Dr. Larimore himself and asked to see the patient back in the clinic to rediscuss operative intervention. So we had extensive discussion about the risk benefits and alternatives, and at that time the patient wished to pursue operative intervention. She underwent a risk-reducing whipple in September of 2024. The procedure was uneventful. Her pancreatic head was soft. Her common bile duct was on the smaller side, making the choledochal Jejunostomy, somewhat tedious, but the procedure went well otherwise. Her hospital course was uneventful. She was made floor status on postoperative day 4, ready for discharge on postoperative day 5. Unfortunately, her hospital stay was prolonged due to placement issues. The pathology resulted in duodenal and jejunal tubular adenomas, negative for high-grade dysplasia. Margins were negative. There were 3 benign lymph nodes, and the gallbladder pathology was benign.
A little bit more of this case. Yeah. So I would just comment on this. Again, I mentioned the name Larry Brennan. I think you might want to look him up. If you don't know him, he's done a lot of surgery and surgical culture in particular. But at his presidential address, the American Surgical, he spoke about this, not this particular disease, but just in general about risk-reducing surgeries. And this is something that comes up in inherited forms of disease where you have a family, autosomal dominant, so have this problem. And it's interesting, as he pointed out, that when you treat an individual with a family that's involved, the success of managing the family is directly related to the success of the index patient. And I've witnessed that as well. So you take a young, healthy person who comes in looking great, you do a prophylactic procedure, things are well, other family members are like, let's say, well, Johnny, everything went well for him. And the opposite, you can imagine the outcome. And unfortunately, I had the opposite side of the story with a patient with family was reluctant to come in to have screening scopes because the mother died from pancreatic cancer. I think an unsuccessful situation. So just to point that out, yeah, I think this is a very fascinating case. But keep it in mind as you go forward, with robotic and minimally invasive approaches, there's going to be an increasing role for risk-reducing surgery because we're getting better at it and safer. But just think about the impact and the management of the family that's related to that index case.
So Dr. Williams did a great presentation. Thank you very much for summarizing that. This presents a clinical dilemma, I think, when these patients are referred with multiple duodenal polyps, with or without dysplasia. If you think about risk-reducing surgery in general, whether it be mastectomies for BRCA1 and 2 mutations or thyroidectomy and Indian 2, which I gave grand rounds on recently, in sort of distinction to other situations, the magnitude of the intervention here is very great. And it's very difficult to sort of assess what the natural history of these polyps are. There may be some sort of interfamilial risk of duodenal cancer that some of these patients cluster in families. But I met with this patient over about 18 months. I met with her a couple of times. I was very transparent about she could continue to have surveillance with endoscopy. And we talked about the magnitude of the intervention. She kept being referred back by GI because she had so many polyps in her duodenum, and she ultimately opted to have local procedure. And I would appreciate Dr. Zavari's comments as well. These are very difficult whenever the pancreas is soft and the pancreatic duct is small, bile duct is small. Fortunately, she did well. But it presents a dilemma, I think. And then my other comment would be, I was lucky enough to be involved in human genetics back in the 80s and 90s when a lot of these disease genes were being identified. And you mentioned Dr. Vogelstein's lab. Eric Fearon, who was a PhD in Dr. Vogelstein's lab, really was the first one to demonstrate the adenoma to carcinoma sequence in the colon. It showed that if you take benign polyps and polyps with dysplasia and cancer, that there's a cumulative effect of different mutations that sort of underlie the adenoma carcinoma sequence. So, if the head of the pancreas is not involved, and there are too numerous polyps in the duodenum, that it will be difficult to remove it or have surveillance on that. We have done total duodenectomy, provided that we have enough of the jejunum to break it up and hook it to the pylorus, and then implanting the common duct and pancreatic duct to the new duct. So create a new duodenum, and then this will be like normal anatomy and avoid the proliferation.
Dr. Spark?
I mean, I congratulate the team for handling this case so well. Let's be on imagination, as Dr. Lerner said. All pancreas, pulled up, it's not male, everybody has got the pancreas, the surgeon and surgical oncologist, so it's clearly difficult to do, risk of bleed is very high, so it was managed very well, and clearly these people are at risk. We give them all the options, but as Dr. Ali said, we have done probably 7, 8 of these total duodenectomy for this indication, and creating new duodenum and gastric bypass with very good result without fear of leak and what have you, but in good hands, he went so well, nobody could argue with that.
The difference between prophylactic mastectomy and prophylactic.
Yeah, just to look at that, great comments. Just to follow the theme of surgical involvement in the disease, I'm blanking out the name of it right now, but I believe it was a southern, Midwestern southern surgeon who was the first to demonstrate the value of Sulindac in this disease and regression of polyps. And it's been effective in some patients in the colorectum, but it's quite effective in the upper GI tract. So was she ever offered any Sulindac?
Yes, sir. I don't really answer that. I don't. You lose her colorectal.
These might have been too big to manage, but certainly there have been some cases where they regress beautifully in the upper GI tract.
What did you learn about this case? What was the most fascinating thing to you as a resident?
Well, just from reading about it, I think the extracolonic manifestations of FAP, that was pretty interesting to me. And I learned that if they do have a desmoid tumor, specifically in a patient with FAP, that you shouldn't go in and try to resect that one. They should be managed medically. So I thought that was something interesting for me at least.
Very nice presentation.
I was just going to make a comment. I think I see lurking colorectal surgery.
Dr. Harrison Gray has the colorectal case. Quite challenging case.
All right, thank you for allowing me to present this case. I'm Harrison Gray, I'm one of the PGY4s. This was a case I did together with Sean Clayton and Dr. Savoy. It was actually an acute care case, and I presented it today because I think it highlights quite well the acuity of our patients, the type of pathology we see here at this facility, and then basically just the operative experience of our residents. I have no disclosures. Our patient was a 47-year-old female. She actually initially presented to our facility as a transfer from an outside hospital for what was quoted to us as a small bowel obstruction with dilated small bowel on their imaging reports. She had told them, and what was reported to us was a 3-month history of kind of vague abdominal pain that was intermittent, colicky in nature. And the few days previous to her presentation at the outside facility had begun to be associated with nausea, vomiting. She had felt some chills and a subjective fever at home, and then she did report intermittent loose stools. Stool guaiac at the outside hospital was positive. She did not have any history of a colonoscopy or colon rectal pathology in her family, denied any recent weight loss of that nature. Medical problems, she had some hypertension and mild COPD. But that was it, no diabetes or anything of that nature. She did have a tubal ligation as her only surgery, which was done 11 years prior. She did have lung cancer and her maternal grandmother and a breast cancer in the family. And then her social history, she did not have any tobacco, recreational drug use, and just occasional social alcohol. So upon arrival to our facility, we went and saw her right when we were notified. She came over to a medicine team. They called us immediately upon arrival. We went and saw her. We found her to be tachycardic, and her blood pressure was about 100. She had reported loose bowel movements within the last 12 hours, as well as a persistent nausea. She was febrile. We were unable to pull up the images from the outside facility. The disc did not work, and the reads were rather sparse. So we went ahead and started off on our own labs and then got our own imaging. These are some of her initial laboratory values. As you can see, she had a leukocytosis. She was anemic. And then with the kind of the vomiting, she had some hyponatremia, very mild hypokalemia, and other small electrolyte abnormalities. Otherwise, fairly unremarkable. While we were doing all this, obviously with her tachycardia, we were resuscitating her with IV fluids and moving forward in that direction. This is her initial CT scan that we obtained at our facility here. You can see here is you do see some dilated loops of bowel, with some mild air fluid levels, but as we move into the pelvis, there's quite a large mass that is occupying most of her pelvis with mass effect onto that small bowel. Different view. So obviously, once we got that scan and saw this large pelvis, it kind of directed our management a little bit into more trying to figure out what this mass was. Oh, not sure why it's doing that. There we go. So we resuscitated her. We did start on antibiotics with the fever. We were unsure if she had any sort of infectious source at the time. The leukocytosis did improve. She intermittently had nausea and vomiting and did refuse an NG tube initially because she was still having the bowel movements, and it was kind of a colicky in nature presentation, and she felt like she would do okay without the NG tube. We did get some tumor markers. Her CA-125 was noted to be 320. AFP, CEA, and CA-19-9 were all normal. With the imaging scan showing a low pelvic mass as well as the elevated CA-125, there was obviously concern for some sort of a tumor of a gynecological nature. So we consulted Dr. Green, one of our gynecological oncologists, to evaluate her and see what his thoughts were. And then, like I said, as she was not fully obstructed, she did not require an NG tube. And then, it was very good example to me of multidisciplinary discussion regarding surgery. Dr. Savoy and our team, and also the oncology team, we had in-depth discussions about when to take this patient to surgery, what their plan was. They felt like because she did have basically the mass effect and there was concern of invasion of this tumor, they felt like we needed to proceed with surgery. But because she was not fully obstructed, it was not emergent. So we were able to resuscitate her in a very controlled, planned fashion, take her to the operating room about 5 days after arrival. So our operative conduct, Dr. Green and his team, they began the operation. They made a large midline laparotomy incision. They performed a hysterectomy and bilateral oophorectomy and debulked the tumor. They were able to visualize and remove the right ovary, but they were not able to see the left ovary. They didn't visualize that. The 14 centimeter mass they reported was quite bulky. Interestingly enough, it was not associated with the uterus in any fashion, which was kind of our initial suspicion was that this was a uterine tumor, but it wasn't involving the uterus at all. There was local invasion to multiple segments of small bowel, and which they did have to resect when they were debulking this tumor. So they did resect some of the small bowel with us there to help them. And they sent off a frozen section, and the pathologist called and basically said, I can tell it's malignant, but I can't tell you what it is, I don't know. So that was interesting. So after the uterus and the ovaries were all out, and this tumor, the main source of the tumor has been debulked, our team then came in and took over and looked at the small bowel and the colon. So we basically ran the small bowel all the way from the ligament of trias down to the rectum to see exactly what was involved. The areas that they had resected from the small bowel just to get the tumor out, there was still some what appeared to be residual disease near those staple lines, so we'd have to plan a resection of those. And then kind of going through our survey, we went down to the rectum and did note that kind of at the rectosigmoid junction right there was invasion of the tumor into the wall of the rectum. And because it was non-diagnostic for the frozen section, we were not sure exactly how much we needed to resect at the time. So we made the decision after kind of all of us there, Sean and Dr. Savoy and I, we talked about, we decided to proceed with a low anterior resection, get as low down below that area as we could to be able to make sure we get all visible disease. We which Dr. Green said if it wasn't any sort of a gynecologic tumor, he felt like debulking in that setting, getting out basically doing a cytoreductive surgery would be the appropriate procedure. So that's what we did first. We started with the low anterior resection. We proceeded. We had to do minimal mobilization of the rectum, but we did mobilize the sigmoid and the left colon along the white line of Tolt. We did identify the left ureter. We took it up probably about 10 centimeters above where this area was. Yes, sir.
I'm sorry, I missed the point, but did she have a pre-op biopsy? You know, going in?
She did not have a pre-op biopsy.
And was there an opportunity for doing a colonoscopy pre-operatively?
There probably was. That was kind of one thing we talked about looking back. When we talked with the gynonc team, they felt like because we knew we were going to surgery anyway, that's why we didn't get a biopsy, because they felt like we were going to have to go resect something anyway. And so they said it probably would not change our management or their management.
Did she have bowel prep?
She did not.
She did not.
We felt like because of the intermittent obstruction, we felt like she probably wouldn't tolerate a bowel prep very well.
The other question I would have is, with all due respect to my gynecology colleagues, I would probably think this is the kind of case that I would want to start as a general surgeon. We're in the habit of the general surgeon. If it's an unknown tissue diagnosis and there's debulking, you're not debulking the right disease, let's say. So of course, in hindsight, it's always 20/20, but that's just an opportunity to point that out.
Yeah, it was another hindsight thing. I think with their discussion at the time, we were all kind of presuming it was something related to the uterus, because the initial scan, the radiologist said they thought it looked like it involved the uterus. So I think we kind of operated under the assumption that it was going to end up being a uterine cancer. And then once they were in there, we were in there, and it was not a uterine cancer, so that kind of changed our calculus a little bit there. So ultimately we did proceed with our surgery. We did the low anterior resection. We were able to resect that rectosigmoid area below that. Like I said, we identified the left ureter. We then proceeded with our end-to-end staple anastomosis via the anus, which did well. We then did a leak test, which was negative. And then we went up kind of proximally to the small bowel after we had managed the pelvis to see exactly how much small bowel we had to resect. Like I mentioned, there were some areas of what appeared to be gross tumor near the staple lines. We did resect those. And then we ended up doing 2 small bowel anastomoses together. There was a discussion at this time, and I would be interested in hearing Dr. Guillem's thoughts on this about whether or not we should do a diverting ileostomy. We felt like with 2 small bowel anastomoses proximal to that, we felt like her risk of leak was probably a little higher from those, just because the tumor had been a little more invasive in that area. So we elected not to do diverting loop ileostomy. We left her in continuity at that time. We did do a very thorough examination of the abdomen after that, and there was no residual tumor that we could see, and everything had been resected. We also had Dr. Green look at it as well. He also did not see anything that he felt like needed to be resected after that. We did leave a drain in the pelvis around that low pelvic anastomosis. She did require 4 units of blood during this case.
Can I ask what was the estimated blood loss?
Estimated blood loss, I looked at the outcome just last night. It was about a liter total in between the two.
What was it in profit? Just technically speaking, what was it that led to that amount of blood loss?
It was largely the debulking. It was, from our portion, was about 400 cc's, and then there was about 600 cc's documented by the gynecology team.
They were debulking what they thought was a gynecological malignancy. And then halfway through that, it became non-gynecological malignancy. So she has a contender that to was peripheral disease.
She does. So post-operatively, she did well. We did leave an NG2 there. She did start walking on day 1. She did have return of bowel function on post-operative day 4. She did have multiple bowel movements in the days after that. Her diet was advanced, NG tube was removed. She did have a little bit of a leukocytosis on post-op day 4, so we got a CT scan because we were concerned about the possibility for a leak given the 3 anastomoses. Very small pockets of fluid, no evidence of leak. With PO contrast. The leukocytosis and she had a small AKI as well. Those resolved and returned back to her baseline. She was then discharged. She had a little bit of a prolonged hospital stay just for physical therapy and disposition reasons, but she was medically doing well. Her pathology came back as a high-grade serous ovarian carcinoma, stage 3C. She had transmural involvement of both the small bowel and the rectal areas of her section, and their section margins were uninvolved. So we saw her in our clinic 2 weeks after discharge. She was walking well, her incision was well healing. She was having a regular diet and is also having normal bowel function. She is currently still being followed by gyn-onc, and they are undergoing genetic testing mainly for BRCA1 and BRCA2. Because if she is positive for those, they can anticipate a little bit of a better prognosis, interestingly enough. Responds a little bit better to chemotherapy, and she is receiving chemotherapy currently. She actually just got a port, I think, 2 days ago. So, yeah.
Yeah, sort of a fascinating spin of the scenario there, but I was going to ask the junior residents if you did not know this case, and let's just say you were asked with 3 anastomoses, and let's just say that you had knowledge that the surgeons who did the procedure felt very comfortable about all 3. In this particular case, which of those 3 anastomoses do you think would be most likely to leak? If one of those 3 were to leak. John?
I would say the colorectal anastomosis, or the rectal anastomosis.
Right. And why do you think that's the case?
I think it's in a kind of more of a watershed area near the rectus sigmoid junction, especially in a case like this where you have to excrete rectal. We didn't, it's not like a robotic case where you can use ICG and see if everything's well perfused, it's just kind of based on what you see. And tumor involvement was pretty bad in that area as well.
Yeah, I would agree a little bit of the watershed, but then I would probably disagree in a way that I think if you had that concern, you just have to consider splenic flexion localization, and then if you take the left collar, you're just going to rely on larger longitudinal, unless they've got some other vascularity problems. Most people have good perfusion, so the watershed is it's a reason to suggest that you should mobilize more. But the other reason is that she wasn't pregnant. There was significant blood loss, and those are the the factors that are associated with looking at statistical. Then of course if it's lower dentist, then narrow pelvis. But so that is the one that you have to consider. And outcome was great, but what could you have done if you chose not to do a permanent SLS? What's the alternative option?
We could have treated it kind of like a Hartman's type operation.
Correct. Great. And Hartman was. This is good timing. Do you know what June 16th is?
No, sir.
It's Hartman Day. Celebrated around the world. We celebrated back at Penn State this past week because last Monday we were having preparation for our week's case, and somebody pointed out that June 16th. We were Wikipedia on Henri Hartman, and most of us in the GI surgical world, we're jealous of Henri Hartman because he's like a household term. Everybody knows Hartman procedure. And that, if you look at that publication, which is, his 100th birthday anniversary was just the 16th. The publication was in the 1920s, 27, something like that. But anyway, he wrote an article, I think in the Lancet or the British Journal of Surgery. It's about 3/4 of a page. And that article has immortalized him. And when you look at Murray Brennan, who's published over 2,000 papers, I think most of you do not know the name Brennan compared to Hartman with one paragraph. But that is an option. That now, as you know, diverticulitis is a pendulum is swinging, but I think it's another armamentarium to keep in the back. In those cases where you're wondering about the risk of leakage, to do that.
Dr. Gray, what else did he ask you about the transfusion? Someone with what you expected.
Well, you can have increased risk of recurrence.
Absolutely. It's an immunomodulator, with any transfusion, whether it's thoracic malignancy, GI malignancy, the chance that you have an early recurrence, even with 1 unit of packed red blood cells or these blood products, is pretty high. Dr. Savoy?
Well presented. Yeah, this was a kind of a test in a lot of things with acute care patients. It was kind of like a board exam. That weekend when she came in, the gynecologist was out of town, and the surgical oncologist was out of town. And that is a real scenario on the boards, and I think getting her resuscitated and planning everything was a good call. As far as diverting her, a lot of discussions were made in the operating room, because our most distal small bowel anastomosis was 15 centimeters from the ileocecal valve, so we discussed that. Okay, the decision: do we do a right colon because this is too close, or where would we bring up a loop if we were going to do it? I think we did discuss a Hartman's, and we discussed, well, she's gotten blood, and she wasn't depressed. That was mostly due to her being obstructed, or kind of partially obstructed throughout, and having a lot of nausea. She was stable otherwise, and young, so we decided to kind of give this a shot by hooking everything up. But it was a good case, a good multidisciplinary case, not something that you see a lot. Sean Harrison did great on the case. They were heavily involved in the decision making, the operating. I think probably Sean's ready for graduation case.
Well, Dr. Guillem, I was wondering when the colonoscopy was going to show up in the presentation.
Yeah. No, my question for the junior learners is the emphasis of the 15th centimeters from the ileocecal valve. What does that mean to you? Why is that even being mentioned? Think like a plumber.
Dr. Vine?
Well, if you'd be worried about obstruction like there, decreasing transit, messing with mechanics right there where it's transitioning to the ceiling.
Yeah, it's the proximity when you wind up doing the anastomosis. Even if you hand sew it and you minimize the amount of valve pulling up, it's too, in my mind, it's a proximity. I've done it a couple of times. It seems to be okay, but it's something to keep in mind. And that thing is mentioned, but that's the way. At that moment, I'd love to get his fixed as well, but at that time, it seems like the better part of balance is just go a little bit more, get that ileocecal out and do a primary anastomosis with this. There's less likely of having two potential signs of limited limit.
I try to be very careful in your oral exams about proceeding without a biopsy. Now, in real life, sometimes it has to happen like this, but Mike Orange gave me a case from Michigan when I was in the oral board with thoracic high mass that he kept saying it's big, it's red, it looks like it's potentially invading the structures. And I did a pneumonectomy without a diagnosis, a big error, a big mistake. And he looked at me, somewhat surprised, he said, well, this was blastomycosis. Obviously, could have been treated better. He goes, okay, I guess we'll go to our next question. Be aware, and I think in this case, we would elucidate something. If they ask you about this big unknown mass in the pelvis, what do you do? What are you going to do in your oral exam? What are you going to do in real practice? And that's that inflection point of when you're going to make those decisions and do that in practice. Dr. Guillem, thank you. These were great cases. I appreciate the residents and the faculty that come these together. I think these are really indicative of what we see here at LSU. Complex cases from GI, from Guillem. Thank you very much. We will proceed now with the executive. Got a local celebrity, Dr. Donald, who's a professor of surgery. Also specializes in surgery. He's an independent surgeon. Started. I would ask the contestants to come down. Just a few caveats. I hope you've watched the regular testing on TV before you've done this. So Johnny's going to go over the rules, but I ask the audience, it's very exciting yourself when you're playing this game in your mind to blurt out what the answer is. So kind of keep it to yourself. It's easy. We don't want this $1,000 money prize money. Now I'll tell you, what I'll tell you is that I think I have to do some sort of handicap. Obviously, we have PGY1s and PGY4s. The knowledge base should be different. There should be a grading course. But I'm going to come up with this unknown handicap system that we consider. So I wish you the best. We already started pushing. Take it away.
So
So the way we're going to do this, I've done it for 20 years at American College of Surgeons, and the rules we've changed year to year because it never seems to work. That, you know, we say, okay, you must wait until I finish reading the question till you can buzz in. Well, then when you've got 10 people, 10 people here, people say, oh, this one buzzed right before you said the last word, this. So we're going to say, you can buzz in at any point once the question is up. Okay, once I start reading, you can buzz at any time. I'll finish reading it. You got 5 seconds to answer or give the correct question. Okay, if you don't, you get minus points, and one of your other colleagues will have an opportunity to give the question. Dr. Samra, I've asked to be the judge, such that, you know, I'll read the questions, I have the answers. Dr. Samra will, if your answer is questionable, he will be the one. Come on up. Set your ugly chair. So, we have a small technical problem here. I see the screen and questions, but Jenny can't get them up here, so.
Sorry guys, the IT guy just got off the phone with him.
Technology kills us, doesn't
Doesn't it? Every time. Every time. I don't know.
We got the screens here, we can see it, but it's not coming up
It's
here.
not coming up there. The IT guy's walking in. Yeah, he's coming. Windows P. I don't know which one to do. Let's see, did I get it? Nope, that wasn't it. Okay. Oh shoot. Help me.
It should give you like a which screen.
It did. Okay.
So you should, where is your projector?
Under the PowerPoint?
So if you do you need anything in like presenter view or anything?
Mm-mm.
No, you should just be able to duplicate it. So just be duplicate. So this showed up what it was meant for.
You can always tell someone's age. Someone under 40 can automatically fix it. If you're over 40, we can never get it to work.
All right.
Yeah, we did. We did already. So I will read the first question since there's got a bunch of folks, and then whoever gets it correctly will be picking the next one. So let's just do. I'm gonna get where I can see. How about that? Let me come off here. I got a mic on, so it doesn't matter. Let's start with crisscross for 100. In the upper mediastinum, this structure travels from right to left in the chest to insert into the left subclavian vein.
Oh, what happened? Team 2.
What is the thoracic duct?
That is correct. I know there was, now the lights are on, so I think it'll work. The lights were not on.
Do a test. There we go.
Okay, now.
Got it.
Okay, they're working now. Okay, you guys can select.
Crisscross for 200.
Crisscross 200. A left non-recurrent laryngeal nerve is associated with this reversed condition. The correct answer is situs inversus. Select again.
Oh, okay. Crisscross for 3.
Chris for 3. results in loss of ipsilateral motor and contralateral pain and temperature below the level of the lesion.
What is Brown-Séquard syndrome?
Brown-Séquard syndrome is correct. Select again. Chris for 4. The cross-innervation of this nerve with sympathetic fibers results in gustatory sweating. That is correct. She said auriculotemporal nerve. Crisscross for 5. Zinker's diverticulum occurs in this weak point in the posterior esophagus between the fibers of the inferior constrictor muscles and the cricopharyngeal muscle.
What is that cricopharyngeal membrane?
Incorrect. Yes.
What is the Achilles trunk?
That is correct. Select again. The pen is miter 100. In 1950, this Australian-born British thoracic surgeon published a comprehensive description of chronic peptic ulcer of the esophagus and esophagitis.
Sorry, no, that wasn't me.
Correct answer, Barrett. Select again.
Yeah, no, let's do meds and men for 100.
For 100?
Yes, please.
Okay.
This brand name antihistamine and this well-known publisher of Poor Richard's Almanac may not mix after the age of 65.
What is Benadryl?
That's incorrect. Remember the category, meds and men. So it's got to be a combination of two things here. Okay?
Yeah.
And the correct answer, and you'll see here what I'm talking about, Benadryl Franklin. Ben Franklin. So every one in this category will be that combination where it'll be two answers in one.
Let's do smile your.
Smile for 100. The minimally invasive operation indicated for symptomatic spherocytosis in a 12-year-old child.
What is robotic or laparoscopic?
Correct. Select again.
Smaller or 200.
Initial management of a patient with intraoperative hypotension and a sudden rise in end-tidal CO2 during lap chole.
What is idiot desufflation? Pneumotherapy.
No, that's not what they've given. I'm not saying it's correct, but it's American College of Surgeons. Yes. Okay. There you got it. Left, right ordocubitus and trendellator. Hindgut for 100. This famous celebrity survived colon cancer. She's also the wife of Ozzy and one of the co-hosts of the daytime show The Hope. Sharon Osbourne is correct. Select again. This bad habit is actually protective of ulcerative colitis.
What is smoking?
That is correct. Smoking. Next.
What is no? Can I get cut the mic up?
Of the hinges, this is class 2.
is diverticulitis with an abscess greater than 5 centimeters.
That is correct. Select Harrison.
400, cut the height up to 400.
This watershed anastomosis occurs between the ascending branch of the left colic artery and the left branch of the middle colic through the marginal artery of Drummond.
What is this money question?
That is incorrect.
What is the next point? What is the next point?
Incorrect. That is correct. What is Griffith's point? Select again, Harrison.
Literally not
300?
Yeah.
Eponymous name given to a rare complication of angiomas involving consumptive coagulopathy.
What is plasma Merritt syndrome?
That is correct. Select again.
Look at left eye.
This tumor is hypervascular and over time it demonstrates peripheral or central nodular enhancement on MR and CT.
Is focal nodular overlay?
No.
What is hepatocellular person?
No. And the correct answer is hemangioma. Select again.
Miles.
Look at left eye 500.
Daily double.
Daily double.
Okay, what's the rules on the daily
Well,
double?
daily double, they have to know how many points they have right now.
Take 3.
So if you're negative, you can wager up to the maximum in any category, which is 500. So if you want to wager 500, you can. They'll wager 5, and no one else can answer this one. If they get it wrong, we go to the next question. Okay. Polyvinyl chloride and arsenic are risk factors for this liver tumor.
Oh, we do need the music.
And the correct answer is hepatic sarcoma. So they get minus 500. These are the 3 specific names of the tinea of the colon.
What is tinea mesocolica, tinea libra, and tinea umbilicalis?
Say it again.
Tinea libra, tinea mesocolica, and tinea,
You said it. Yeah, you got that. I just couldn't hear it. That's correct. Select again, Harrison.
let's just do tennis light here for 500.
The surgeon published in 1964 article, A Method for Extraction of Arterial Emboli and Thrombi, in a gynecologic journal. That is correct.
Nice.
The minimally invasive procedure that employs the trocar positions shown here. And correct answer is totally extraperitoneal hernia. Select again. The author of this 1970 paper established a thickness-based prognostic system for melanoma. That is correct, resident. Select again. In 1935, this surgeon was the first author on an article describing his treatment of carcinoma of the ampulla urvata. That is correct. This duo published a 1955 paper describing the relationship between pancreatic islet cell tumors and peptic ulcers, followed by a 1964 paper describing the condition named after them. That is correct.
For 500.
If this former CBS Evening News anchor were to manifest an acute rise in end-tidal CO2, tachycardia, and muscular rigidity after induction of anesthesia, you'd want to administer this medication. Remember the category. And the correct answer is dantrolene rapid. All right, select. A liver mass with strong uptake of sulfur-colored skin.
What is focal nodular hyperplasia?
That is correct. Focal nodular hyperplasia. Select again.
Liver
Eponymous nomenclature for division of liver segments.
What is going on second?
That is correct. 2.5 seconds. Select, Sam.
We'll do smile for 3.
Seems everyone's avoiding that men in medicine. The most common presenting symptom of the pediatric small bowel pathology shown here.
What is painless bleeding per rectum?
That is correct. Painless rectal bleeding.
Smile your on camera.
The intra-abdominal pressure at which cardiopulmonary dysfunction occurs in normal volemic patients undergoing a lap coding. Correct answer, 20 millimeters of mercury. Well, I guess we got to go to the dreaded category. All right. In the book of Genesis, this crop farmer probably didn't subcutaneously inject any of this numbing medication into his younger brother before killing him, but may have given it intravenously as a cardiac depressant.
Who is like a king?
That is correct. Some opponents might suggest giving this agent commonly used for rapid sequence intubation to this NFL quarterback who won 4 Super Bowls, but is also known for his role in Deflategate.
What is he, Tom? Tom Brady? Tom Brady?
We'll give it. That is correct. He Tom Brady. And the final one. Basketballs weigh 6.24 times 108 of this metric unit, a weight well known to this 1990s NBA All-Star who was known for dunking while playing for the Chicago Bulls.
Microgram Jordan?
That is correct. Well, that was good. All right, we're going to put this last board up.
Team 1, 400, Team 2, 2100.
minutes of fame will get you if you win, or the size of the tool pictured here.
What is it, 15 weight?
That is correct. Select again.
Tool behind the tool form.
Cardiac surgeon for whom this instrument is named.
Who is Dr. B?
Dr. Michael DeBakey, born in Lake Charles, Louisiana.
Short road example, 600. Tool behind tool on 600.
This thing is not like the other.
What is it, malleable?
That is correct.
Tool behind the tool frame.
Used to extend an arteriotomy.
What is possible?
That is correct. Select. The modern equivalent of this instrument shown here. Yes. That is correct. Virchow's triad refers to these three risk factors.
Yes.
Hypercoagulability.
Endothelial damage. And, these are six.
That is correct.
Team member, 400.
Migratory thrombophlebitis is a concerning sign for this cancer.
What is Stewart syndrome or angiosarcoma?
Incorrect. That is correct. Select again. Fibromuscular dysplasia most commonly affects these vessels.
What is the renal arm?
That is correct. Subclavian artery stenosis is usually caused by compression due to hypertrophy of this muscle. That's correct. I'm being nice. Effort-induced thrombosis of the subclavian vein is also known by this eponym.
What is Hashimoto's?
Yes. What's Patrick? What's that?
You gonna give it that one, Sammer? Okay, Sammer says give it to him. Patrick Von Schroeder. You would have gotten it on multiple choice, but
Bad to the bone for
this is the most commonly affected compartment in the lower extremity compartment syndrome. That is correct. This classification scheme describes epiphyseal injuries.
What is Saltaires?
That is correct.
Let's do hypothetically for 1,000.
So how much do they have, Tammy?
2,400.
You can wager anything up to.
Yeah. Oh. Wager 2,400.
500. Answer is associated with cardiomyopathy, weakness, and hair loss. Answer.
What is hypothyroidism?
Incorrect. The correct answer is hypocalcemia.
Any questions?
All right. Sam, select again.
We'll do bad to bone 600. What's your 500?
Oh!
might get it back.
300.
300. The answer is compression of this nerve root results in impaired dorsiflexion and decreased sensation in the big toe web space. Answer?
What is the peroneal nerve?
Incorrect. Correct answer is L5. Select.
It's a kind of a vague question because they ask me the nerve and you're giving the dermatome.
No, they asked her.
They asked her which nerve root. Yeah. That was the catch. Didn't say nerve, it said which nerve root. So, all right, select again.
Double duty, 600.
Instrument with a bend at a 90-degree angle.
What is the right angle?
Correct. Select again.
Let's do his hernia without.
The name of this physical finding manifested by medial thigh pain with external rotation of the thigh, most often seen in patients with an obturator hernia.
Is that no, well,
Okay. That is correct. Romberg. So select again. This painful complication from inguinal hernia inguinal hernia repair can eventually result in testicular atrophy and is the result of excessive dissection of the spermatic cord and entry to the pampiniform plexus. And correct answer, ischemic orchitis. Select again.
Which one? His and hernia?
2 to 3 times more common in men, this type of hernia is located between the umbilicus and sternum and frequently multiple and painful out of proportion on exam due to the presence of incarcerated preperitoneal fat. That is correct. Okay, you got to select. This type of hernia is most often seen in elderly, multiparous women with poor nutrition and should be repaired with a trans-abdominal approach. No. That is correct. Select. Although seen more common in males, this is the most common type of hernia in females. That is correct. Select Harrison. A proximal ulnar fracture with radial head dislocation is also known by this eponymous fracture. Correct answer is Montego fracture. Select again, Harrison. A supracondylar fracture places this artery at risk and may result in a contraction.
The brachial artery?
Incorrect. Incorrect. The correct answer is anterior interosseous artery. Select again, Harris.
Let's do double duty for that one.
The technical and colloquial surgical removal of wrinkles present on the part of the head containing the eyes, nose, and mouth.
What is a facelift? Doesn't seem to be too. Incorrect.
It is, you need, it's two terms, two words, so incorrect. Correct? You had half of it right. All right, select again. The ligament that connects this antibody-producing organ and the left kidney.
What is the spinal renal ligament?
Ah, that's fine. Thank you. Well, I'm already there. All right, select. Names for the instrument shown here are Charlie Brown and his gang.
What is that, kicker?
That is correct.
We'll do
Operation whereby the head of the pancreas is removed and intestinal continuity reestablished.
What is a Whipple or pancreatic enlargement?
That is correct. Select again.
800.
Its rapid correction is associated with central continental analysis.
What is hypometry again?
That is correct. 600. May manifest as hyperreflexive, perioral numbness and tingling, and prolonged QT interval. That is correct. Hypocalcemia. 400. Most commonly seen in patients with refeeding syndrome.
What is hypophosphatemia?
That is correct. And the final. Risk factor for coarse palm.
What is hypomagnesemia?
That is correct. I think if we had another board, Miles is now getting. Okay, so we have final jeopardy. Tammy can tell everybody's point total. Well, total, overall. We need overall.
So T1 has 1,400, T2, negative. 1,800.
That's fine.
5,700.
We're sorry that you don't get to participate in final. We appreciate your participation. So, 1, 2, 3 teams participating. I want each of you to write down here what you want to wager. Okay, what do you want to wager? Put it down on the paper.
51 and 57.
Pretty good. Well, keep that paper. Keep that paper because you're going to have to write your question down when we do the thing. Has everybody got it down? Sam, you got it? Strategize. You got 5 seconds.
All right, we're ready.
All right. So, the category is a little too close. Now, you don't buzz, you just write the answer down. You got 30 seconds. Once we read the answer, you have 30 seconds to write the question down. Answer is, this Stanford neurosurgery chief resident, who had a master's degree in English literature, recently became posthumously famous for his New York Times best-selling book. All right. Who had the lowest total? No, not negative. Okay, so what was your question? What did you write down?
$1,600. Who is Dr. Abdul?
That is incorrect. So minus 1,400.
Once we get to the first name and the title of the book.
He wagered $601. Who is Paul?
Who wrote it? Becomes there.
Well, that's half correct, but it's not correct. You got to put the name. The name is, well, I won't say it. What's your answer?
600.
How much did you wager?
We wagered 600.
So 601 minus for them, minus 601 for team
Two.
Team 2.
And team 4.
They won because we wagered 4,600.
So the correct answer is Paul Kalanick.
We'll have a check in the mail for you guys. You got it. We'll take it.
But the problem is, I never really did even put that hard question.
You know, that's fine.
That was the governor got shot, right? Yeah. But actually, it's so funny though, the governor got shot in the second. Yeah. Exactly. That's where they showed the gun.
Go ahead, I said it. They don't say anything about the surgeon getting called to come help them. They call, I think which one they call. So we come over and say, hey, okay. I think I'm really complimentary. It's part of the story. I forget who it was that they, well, what you were talking about, a different party? It's something like that. They had a disagreement a long time ago. I may be fuzzy on the details, but they went out there. Well, of course not. I mean, that's why you don't ever find out which prison they go to jail.
You're looking for somebody. Thank you.
Professor Clay.
Sir, how are you?
Oh, was there? Goodness.
Is that your speech ready?
Oh, yeah.
It's all typed out? How long does it last?
7.
I think we need,
Oh.
Bailey
Oh, you
and,
rehearsed it?
Dion.
I think the longest one.
I was gonna have to handicap it.
Nobody's doing it long.
Who's for 10?
I'm so impressed.
I don't know that for sure, but I guess.
Not gonna be like arrows and bows.
Yeah.
For an
We're
hour.
not gonna have
Get a tree crying again. Get about in a crop.
I might when I get to the part about my wife. Okay. At the end. We'll see.
Arrows and bows.
I only suggest you cry about that.
I'm the emotional one of the group. Most people don't understand that.
True, yeah. Talking about the pigeons.
Yeah.
I talked to him a few weeks ago. He's doing good tonight. Mentally sharp. He's blind pretty much. He was in Georgia when I talked to him, but he goes back and forth.
Does he still have cameras in Conway that he can see on his phone?
Probably so.
Mark Brown tells a story about how they will talk about patients.
Amber showed me a picture.
Yeah.
You know,
And then,
Oh,
I said to Clay,
gunshot wound to the chest, I never heard
He kept clear.
Remember the Guillem one? You said good.
Sarge, walked into that emergency room.
So Donnie, how long did Gil practice after his paraplegia? It was like 20, 15 years? Because I remember when I first started with K, he, before he had his injury, he was doing training for Ironman places and stuff.
He started here, I think, in 2010.
That's what I thought.
Very hard to beat it.
I still talk, I go by and see him every so often at his house. diabetes? Is he had diabetes?
No.
No?
Even I called that brother, so.
I was like, this guy's research is saying this is correct. Option was gonna take over here, you know, when we can announce that, that's
He was posted.
Yes, I know.
I was posted.
I did.
He looked like he was ready to be done.
Wow.
Yeah, I saw him in the hospital.
Did you?
Samper told me he was there, and I said,
Dr. Gill?
he recognized.
Yeah. Oh, yeah, sure.
I was just telling him I did Dr. Gill's last case.
Did you?
Yeah.
What was it?
It was fishing.
Fishing?
Yeah. You can tell about time. He was getting real shaky. He's nicest guy. It was so nice.
Wow.
Yeah. Dr. Griffin, I did my first case with. We did Dr. Gill's last case.
He said, I know, and I said, you're not a contract.
I got the last roast by Dr. Griffin before.
That's good.
Well, I said, hey,
Sir? We're gonna do that next year?
Yes, y'all want?
That was good.
That was good.
Yeah, I thought that was really good. The case presentations were awesome.
Yeah, I thought so. They did great.
there's no hope.
That case was
No, it's a funny way, I can't give y'all bonuses or rewards, I have to work it into where it's in your salary, so they'll send you a check for the winner, whoever won the award. So I told you, so I got some money I want to donate from our foundation to the residents, who win these contests. Oh, you can't do this, I said, make it more difficult than it is.
tax-free.
Yeah, exactly. And then that, you gotta tax everything you do.
Right. I bet it's better than a bookstore.
That was actually the best part of my
I think there was like a lot of money
Well, there's not much.
from unspent certificates.
The thing is that Barnes and Noble moves in and owns, opens their own bookstores and so like last year, I don't think they come here.
Yep. I think I saw a couple of certificates. Got a big old
They got, gonna be late coming in, ain't they?
Well, they are told. Russell them up.
You said 10 in hand, didn't you?
10:05.
I don't know if you're coming in there or you're on that.
I'm coming to
You're on. Yeah, I'm on. You're on this one.
We go home, take a short break.
You were on last night? Yeah. It's a long day. Wait. It's a long day. What time we gotta be there? 6:30? 6.
Griffin is good.
Oh, is it good? That's good. Dr. Bailey, is that a strut that I saw there? I think it was. It's just a mild strut, and that's quite all right. You deserve it. You know, the in-service exam threshold just went up for you guys by about 30 points. So, all right. Sammer, could you check and see if we get everybody in? I think we. All right. Get started. Dr. Griffin, great. Hey, Dean, thank you for coming. Appreciate you so much. I'll tell you in starting that I had a ton of slides on the history of LSU surgery, and most of you have seen these slides. I have a penchant for the history of where I've trained before, whether it was Utah here or Philadelphia, and I can tell you I have to hold back my energy because history tends to repeat itself if you don't pay attention to it, and that's a famous quote, obviously. But what I see in just a short prelude to the introduction here, where I see surgical training that is where it's come from and where it's going in the future is if you look at our history back in the late 19th century, where Department of Surgery started training people in Shreveport by great numbers, especially in the early 1900s. Now, were we affiliated with academic institution? Absolutely not. The first two names of our hospital system, Shreveport Charity Hospital and Confederate Memorial, have fallen by the waysides, not only because they needed to change their name, but because we really migrated into a university program in the early 70s. Dr. Kurtzwood in 1971 came here, and when it became LSU, that's when it officially became an academic teaching program. But if you look at the history, for almost 75 or 80 years, the community physicians ran this program, resident-run program. The community physicians would visit every so often and come and see the chief residents. But the chief residents were the kings. They did the trauma. They did the acute care settings. They did a lot of surgery, really without a lot of supervision. And if you look at the outcomes, which I have looked at the mortality in different decades and quartiles throughout the century between 1900 and 2000, when the community physicians oversaw the Department of Surgery and the charity hospital system, that the mortality was not far from what it was now. Now, we couldn't operate on a lot of people, and some people came with morbid disease where they weren't operated on. But if you look at the operative cases, you'd think that we would have expanded and expounded on mortality, but the mortality was not dramatically different. So where do I see the Department of Surgery going from here? I do see that initiation and the kind of spreading of the surgical teaching parameters in the academic and in the private sector is just going to change. Me and Jose were talking about this earlier, about he has a lot of hybrid surgeons who are private practice and academic practices. But especially with this great big beautiful bill that we see coming across Congress pretty soon, it's going to change where patients go. And where patients go is where academics have failed in the past. And when they have sometimes an easier route to enter a hospital, it's not necessarily a teaching hospital to go to. So that's why it's important for us as a hospital, and for me as chair and on the administrative team of Ochsner, is to push Ochsner to make this a hospital that's equivalent to any center in the state, in the region, where our patients will want to come here. And number one, get great outcomes, and we can take part in surgical education. So I'm a little concerned about academic medical centers, and if you talk to the chairman across the nation, they're concerned likewise. They have to produce a product equally as good as Northwestern, as Duke, as some of the great centers that we all know, Mayo, Sloan Kettering, to get those patients there, to number one, to take care of the patients, but also provide adequate surgical education. So that being said, we're in kind of a change in our program now. We've seen some of the numbers with Medicaid expansion and some of the numbers for teaching gone down in some of our basic general surgery cases. Now, if you look at the things we do well and are very competitive at, such as vascular, obviously trauma, we have no problem with the number of patients that come to our institution. But some of the basic standard cases that we treat with hernias, cholecystectomies, colectomies, and things like that, we're challenged now. So I think we're going to have to rise to the occasion to be able to produce good clinical outcomes at a fair price and have access where patients want to come to us, and not just through trauma, not just through advanced quaternary care. So I'll end with that, just to say that I do see that the role of the community physician is going to play a greater role in graduate medical education. I've spoken to my partners at Willis-Knighton. They've been doing that for years. They've taken part in transplantation at our associated, we called it a private hospital at one time, but actually is an academic medical center in its own right. But you're going to see, I think, diffusion of medical education through not only academic centers, but also through the private sector. So I think it's important for us to encourage that, to make sure that not only are private physicians involved in graduate medical education, but even in research. So I think the triple threat of being a researcher, educator, and also a surgical mentor and teacher is somewhat hazier than it was in the past, but nonetheless, it's our duty as surgeons to continue our grand educational experiences with you guys. But we do have to remember we're here for patient outcomes, good patients, and making sure that the patients come to LSU so we can treat them appropriately. And I'll stop my editorialization there, but I do see a change in the paradigm of graduate medical education, and I want to be part of it. And we're having to kind of morph our system right now to make sure we are part of it. But without further ado, I want to introduce Dr. Abramson, who obviously is not with us, but played a huge role in his role as an academic surgeon, but also as a private practitioner. He primarily was in private practice. This is Dr. Paul Abramson. When he was chair, just announced his chair in the early 50s of not LSU Medical Center, but Confederate Memorial Hospital, which started in 1953. His history is he and his family migrated here from Poland in the 1800s. His father was a physician and trained at Tulane, which was the only surgical training program at that time, actually university affiliated, and was the only medical school in Louisiana until 1933. He joined the forces with T.E. Shumpert, and most of the local people here know who Dr. Shumpert was. He was the total surgeon who actually started one of the biggest healthcare organizations that Shreveport's ever seen in Shumpert Hospital. Dr. Lewis Abramson, Dr. Paul Abramson's dad, opened the North Louisiana Sanitarium in 1907. This is a picture of that, which sits now, I think, where the Willis-Knighton Rehab Facility is, up on a little hill, not far from the previous Louisiana Crime Center. As you can see, this Ferrari here, a Porsche, this is sitting in front of North Louisiana, and a lot of it was horse and buggy still during that time period. So Dr. Abramson was educated at Shreveport Public Schools. He went to LSU in Baton Rouge and finished at Tulane in 1927, and went to Tulane Medical School in 29, and interned at Charity in New Orleans. And Charity Hospital, as you all know, started in the late 1700s and early 1800s. Came back to Shreveport and joined his father at the hospital we just showed. Immediately became training surgeons and became a mentor at a very early age in his surgical career at Shreveport Charity Hospital. This is where Shreveport Charity Hospital was on Texas and Murphy. It's up on the hill over by the old police station. He became a fellow of the American College of Surgeons in the 1930s. He, as most of his peers did during that time, joined the European Theater in the Tulane Surgical Field Unit as a major and stayed there for 3 years. But he did so much more than that. His community service in Shreveport was just tantamount. If you look at a Google search, not a Google search, but I should say a search in the Shreveport Times newspaper that takes you back into the 1930s, I mean, every day he was part of some sort of social endeavor, some sort of educational process for not only the physicians, but also for the people in the community. Here, he was asking people to purchase seals, which were like Easter seals and Christmas seals for people with tuberculosis. It was almost always either on the radio station and trying to educate the public and also the physicians about the need for health care in Shreveport. He examined babies at the fair, believe it or not. So he did it all, not just a surgeon, but also just interested in the forthright help of his community. He would go to the YMCA, as you know, the old Y downtown, which was built in the 30s. It was a frequent visitor from him. And once again, as not too many people know him, I think Dean may have been affiliated with Dr. Abramson in the long past. Most of us only can read about this great gentleman and surgeon. He joined the Army, as we just discussed. He was a Shriner, active in civil defense and a Rotarian. Community outreach was pretty impressive. Became the president of the Louisiana State Medical Society and also the Shreveport Medical Society and the president of the Louisiana chapter of the ACS. He became department chair here before it was called LSU from 1951 to 1959 and had probably the most influence of any surgeon prior to John McDonald, who started in 1977. There were dedications of libraries for this man. An educational fund was started after his demise when he was 53 years old from an MI, that they thought so much of him that they wanted to memorialize his name, memorialize things where people could remember what a great teacher he was. And the Abramson Fund is still in existence now. Stacy will tell you we have funds, and we've had this donation not only from people in the community, but also our own staff and faculty. So it's extremely important that we remember him, we eulogize him, and this lectureship today is named after him. This is Dr. Paul Abramson with Max Green of New Orleans. Dr. Abramson was taken over as the president there. Notice the dress of the time, white tuxedos. And this was in Alexandria, Louisiana, of all places. He was also a member and helped the Shriners Hospital start, which was one of the first hospitals in Shreveport. And unfortunately, at age 53, same pathology that took his brother and also his father at an early age, died of a myocardial infarction while he was at home. So after his passing, several of the surgeons in Shreveport got together and said, look, we've got to memorialize him. So they got a large fund and started in 1972 a visiting professorship. The first visiting professor in 72 was Dr. W. Dean Warren, the gentleman who made the splinter renal shunt well known. Dr. Warren has since passed. Dr. David Sabiston was the fourth speaker. And if you look at the names of the Abramson speakers in the past, it's pretty remarkable. Michael DeBakey had been here. Dr. Julie Freshlage was here a couple of years ago during the pandemic, unfortunately, virtually, but still nonetheless with us. And just a huge number of names here, from Norm McSwain to William Wood, just big names in surgery. David Richardson, Kurt Tribble, Hiram Polk was here, I think, prior to this list being made, and Dr. Ajit Sachdeva, who's really head of the educational department of the American College of Surgeons. And it's funny how when things come around, it goes around. This is Alton Ochsner, who was the immortal enemy of LSU back in the 30s when our governor basically took him out of Charity Hospital, one of the most talented surgeons in New Orleans, and he had a disagreement with the governor, and Jose and I were talking about the politics in Louisiana, especially in this area, and our governor at that time, Huey Long, took him off the staff, and Dr. Alton Ochsner was no more at Charity Hospital. Now, subsequently, he got readmitted to Charity because Tulane was not going to come back without his leadership. But that battle between LSU and Alton Ochsner is what started Ochsner Clinic. And it's funny that we're now affiliated with that institution. This is Dr. John McDonald in 1980, showing the picture and unveiling the picture of Dr. Abramson that's over near my office. I'd ask you, if you don't remember him, just go by and take a picture, take a look at his picture. So without further ado, I'm here to introduce Dr. José Guillem, who has been a friend of mine for several years, introduced to me by Dr. Griffin. He's currently chief in division of colon and rectal surgeon at Penn State. He's a tenured professor of surgery and is associate director of surgical research there. Most of his education took place in the northeastern United States, where his undergraduate degree was at NYU, his MD degree and his MPH at Yale University, and he got his MBA from Brandeis in Massachusetts. Surgical training, very impressive. He stayed at Columbia Presbyterian for his general surgery and his 2-year postdoc fellowship, a research fellowship with Dr. Bernard Weinstein, who created the field of molecular epidemiology and the liaison, and noting one of the first physicians to note the connection between products that we burn and make in our environment and cancer. He was a colorectal fellow at Leahy Clinic, and in 1991 started a multi-decade career in cancer, colorectal surgery, clinical genetics, and familial colorectal cancer syndromes at Cornell University in Sloan Kettering, where he's made his name. So he's been on the board of the American College of Surgeons as a governor. He's a member of the Southern Surgical Society. Multiple research awards has been given to Dr. Guillem. Over 300 peer-reviewed publications, 67 book chapters, and served as principal investigator on several NIH trials. Without further ado, we're so happy to have him today to talk about something that's near and dear to our heart in Louisiana, of yellow fever. So Dr. Guillem, thank you for coming today, and we're so excited about having you.
Great. Good morning. Thank you, Dr. White, for that kind introduction. Just want to make sure, are there parents being involved in this? Are they?
They're probably on YouTube.
Okay, so I just want to.
YouTube is active right now. So
Excellent. Terrific. Thank you for the kind introduction. It's first of all, I want to welcome everybody, especially the parents, the families and friends of our graduates and residents, and if there are any medical students, I see faculty and friends and all those who've been involved with LSU Health Shreveport. I think we're here to celebrate the singular accomplishment of these 4 or 5 outstanding graduates who are with us today and are launching out into their careers. And I hope that what I can share with you today will be some examples of challenges that I have faced along the way, starting with my experience in the jungle in Ecuador through my surgical training. And I think when I reflect back on those experiences, they have left me with some memories of how I overcame some of those challenges, the mentors that I met along the way that today, to this very day, continue to inspire me. And I hope that you will also develop your own stories, as I'm sure you will, stories that will help you as you go forth and have your challenges that I think will give you some opportunities to recognize that we're all learning, we're growing, and we're getting more experience. And that will give you some levels of confidence that when you're challenged, that you know that you will always do your very best to always do the best surgical technique when you're doing it, take the best care of your patients, and know that you have the mentorship and support, as I have of mine, well, you can always turn back to, just a phone call away. So I congratulate you on your accomplishments, and I hope that what I share with you today will provide some inspiration, perhaps, in learning lessons on how you can also go forward. I was asked by Dr. White to give this lecture, and he was very kind on the one hand to give me complete rein in terms of what the topic should be, but he also specifically said, I'm not going to give you the subject matter, Jose, but I just make one request, and it was, quote unquote, encourage you and motivate us. Do something that will encourage and motivate us. So no small task, Dr. White. Thank you very much. So I'll try on that note to do that. So I have no disclosures, no commercial disclosures, but I will say I did not contract yellow fever, sorry to disappoint you, but did contract dengue fever twice. I'm going to share some lessons that I've learned along the way through my medical school days, surgical residency, as a faculty at Sloan Kettering, research at Columbia, and then some timeless wisdom that I've learned from many, many colleagues, senior to me and junior to me, as we go along. So this is what's dear to my heart and will be dear to your heart as you look back on your training. This is Yale Medical School, where I went to school, that was pointed out. And part of the curriculum back then was a requirement that you had to submit a thesis, research thesis, prior to graduation. And most of us took advantage that first summer after the first year to try to identify a mentor, a topic, something to get some data going early on. And I was extremely fortunate to meet this gentleman, Dr. Wilbur Downs, who was a naturalist, a virologist, very fascinating man, very colorful individual, who had served in the Army in Trinidad when they were trying to eradicate malaria many, many years ago. So he had some field experience and a very colorful, multidimensional person, a
appreciated by the community as well as the faculty of both the medical school and the School of Public Health. So they started this Downs Fellowship at Yale for medical student research in global health. So I thought, this sounds interesting, let me approach him, and I did. And he said he wanted me to meet this gentleman in Ecuador, Ernesto Gutierrez, who happened to be a virologist who had been at Yale a year beforehand, looking into what was happening in yellow fever in Ecuador. So I wrote to him, trying to find a mentor, because the requirement was that you needed a thesis, you needed a research question, a hypothesis, and a mentor both at Yale and wherever you were going. And without giving you the nitty-gritty of the story here, but he basically points out that an outbreak had occurred in the jungle of the Zamora Chinchipe, and almost in the Peruvian border of Ecuador, and that country, Ecuador, was trying to figure out what was going on. And at the time, the big question in the world of yellow fever was trying to understand whether the virus was always endemic and zoonotic in that region, or whether it was moving like fire throughout the jungle. And one way to try to understand that was to go to the site where the outbreak had occurred in humans, and now that it was no longer present in humans, to go back and isolate the mosquito that was transmitting this disease and try to find if the mosquito had the virus. And that would support the theory that it was endemic and zoonotic. So they told me the story. I was super excited. And this is where begins the sort of the anticlimactic aspect of this, because here I am, a total neophyte, super excited, and I'm beginning to meet some luminaries of the field that I didn't appreciate who these fellows were at the time until later. So Wilbur Downs introduced me to Robert Shope, who from the Shope papillomavirus, he's the son of that individual, first of all. And Robert Shope at the time, the nicest man you could imagine, had all the time in the world, especially with me, and suggested that I meet Thomas Aiken. So Shope had been perceived as a person who had found more viruses at that time than anyone beforehand. Tom Aiken was a naturalist entomologist who had a lot of contributions to taxonomy, but also taught hands-on experimental things. So they suggested that I go to the Gorgas laboratory in Panama to try to identify the mosquito, the vector, this little fellow here, the Aedes aegypti. So I spent 2 weeks in the Gorgas lab and in the jungle as well, trying to isolate this and identify it with a microscope. So I felt pretty smitten at this point. I said, these three luminaries, these legends, are trusting me to go to the Amazon and to provide me with this textbook, the yellow fever textbook, which is about almost 3 inches thick. And then as I flip the inside cover, I try to figure out what this book is and what the signature is. And that's Max Tyler, who I didn't know who that was, but he's a Nobel laureate in the 1930s for having developed the live attenuated vaccine for yellow fever. So I'm saying, wow, they're trusting me not only with this research question, but this amazing book. And the other second Bible they gave me was this one. This is the Arthropod-Borne Viruses of Vertebrates by Max Tyler and Wilbur Downs, the gentleman that I had just shared with you. And in the inside cover is Robert E. Shope. So I'm like, I can't believe I'm so lucky to be in this position. I better do a good job here, because someday I've got to go back in the fall and present to the benefactors what I did with their money, essentially. So here's my trip, my journey to Guaycimi. That was a small town, small little hamlet in the middle of the jungle. I would leave from New Haven, go to Panama, and then go down to Guayaquil. And I don't know if I can show you on the map here. Yeah, here it is. So I'm from Puerto Viejo. That was the small city. Guayaquil is where I was going to meet my mentor, Ernesto Gutierrez. And then we would fly up to the Andes and Loja, right down here. And then we go to Zamora Chinchipe, Guaycimi, which is right here in the Peruvian border. But I will tell you that my real modus operandi for going there was my grandmother, who was still alive at the time, was living in Puerto Viejo. So I said, I better go there. While I do a little yellow fever research, I'll visit my grandma. So it was not going to happen, because I got sick when I was in the Amazon. But here we are in Guayaquil. This is the equivalent of the NIH in Guayaquil. And I met up with Ernesto Gutierrez, my mentor down there, who was the one that communicated by mail. And at the time, that's me in the middle here. To the right side is Dr. Garcia, who was an entomologist as well. And this is Miguel Mendoza, who was our research assistant, as well as our bodyguard, as we were going deep into the jungle, needed some protection. So we, again, would leave from Guayaquil, ascend up to the Andes, descend into the rainforest and into the tropical rainforest of Zamora Chinchipe. And this is majestic Andes. If you have not had a chance to visit South America and travel through the Andes, I can tell it's phenomenal. Haven't seen the Alps and haven't seen the Rockies as well. There's something special about the Andes that highly recommend. Great skiing down in Valle Nevado in Chile. Great place. You can fly to Santiago within 2 hours, ascend up to some great skiing in the summertime. So this is Loja, which is a city that I mentioned earlier, about 9,700 feet above sea level. Spent a day there getting some of the equipment. And the next day, and we were assisted by the malaria eradication unit that was very highly coordinated by Dr. Gutierrez for us to descend this treacherous hairpin turns through jeeps and different ways and a bunch of rivers. And that makes sense because the Andes have such a tremendous release of fluids heading down to the Amazonian region. And this is Zamora. We spent the night there, and you get a glimpse here of the Andean rainforest. Spent the night there. The next day, we crossed multiple rivers. This is the Zamora River with, I didn't focus. My daughter, who's a photographer, and I was upset that I didn't have the right camera for this, but there's Ernesto and Dr. Garcia. Multiple smaller rivers. Then we're down now to the tropical rainforest, Sangarita River. We did this most of the day, eventually got to the area near Zamora and Chipin. The remaining 3 to 4 hours were on foot, on mule and horseback, as you can see here. And here's my mentor, Ernesto Gutierrez, with Mr. Jimenez, trekking through the rainforest. And this is a shot of Guaysimi, the small hamlet, which was taken the morning after. But when we got there that evening, pretty close to sunset, lots of fogs and rain, couldn't see anything. And when we got to this open space, Ernesto Gutierrez says to me, "Jose, look around, what do you see?" And I said, "Nothing." He goes, "Precisely." I said, "Where am I?" He goes, "This is Guaysimi. You're going to spend 2 months here." I said, "How about you, sir?" He goes, "I'm leaving tomorrow." And he did. He was a smart man. Went back to Guayaquil, and I spent 2 months here, which was an amazing experience. And I can tell you, I'm so lucky that I kept these slides. We were talking about it last night. These are Dayezo slides, and thanks to Dr. White for the invitation to come here. I remember someday I'll use these slides for some purpose, and I'm going to share with you this experience that I had. And again, fortunate that I retained some of these photos. In this small hamlet, which was fascinating to me, 15 years beforehand, an Austrian missionary group had arrived, and there was nothing there, but they built a church, they built a building, they built a school, and we were provided housing as well as a room for a makeshift laboratory. The next day we went out, and the assumption was that these mosquitoes would congregate in the canopy below the top of the canopy of these trees, and you can zoom in, you can see a monkey up there. And the plan was to go into that canopy and put in mosquito nets, capture the mosquitoes, bring them down, and then, as I'll show you, have them inoculate a guinea pig, and the guinea pig's brain would be harvested, and that would be transported back to New Haven, and then we would look to isolate the viral particles in that brain. And again, if we would demonstrate that, that would support that it was an endemic. So here's a local young man that we contracted to secure these nets there in these baskets. And then these were brought down, and to confirm the presence of Aedes aegypti, here's Professor Garcia trying to identify them. Here's the net, and here's Mr. Melendez demonstrating the vial, that then we would bring this into our makeshift laboratory, which was also serving as our bedroom. And in these netted spaces, we'd have the guinea pig shaved. And the plan was to try to get as many bites on these guinea pigs, and that would support that maybe they had the virus within them. And we did this repeatedly once a week, and then we would freeze the brain and go through this treacherous trip on foot, up the rivers, cross the bridges, up the Andes, up into Loja, deposit them, and they would be transported back to New Haven. So this went on for about 3 to 4 weeks. I got sick in the middle of that. I'm not sure what I had, probably a bunch of different things, but later on I realized that dengue was one of the things that I contracted. But still trudging along, optimistic that this was going to occur, that I would have enough data, that these luminaries had entrusted me with all this expense and time and phenomenal books, but I still had to deliver. My deliverables were to present to this group, to the School of Public Health and the School of Medicine, some data. And I began to, this is where I started spiraling. And this is where it's important for you to realize that, try not to spiral, but I was like, my God, I'm not going to have anything to show. So after the 4th or 5th trip, I remember calling Dr. Downs when I was up in Loja. I called him up, And remember, this is the military gentleman who had spent several years in Trinidad in the field. So I called him up. I said, Dr. Downs, it's José Guillem here, sir. I'm having a difficult time. I think I want to come back. I'm not succeeding. And he goes, Jose, this is Wilbur here. Over. I'm like, he thinks he's in the field still. So I'm like, yes, sir. And he goes, well, if I understand correctly, you want to come back to Yale prematurely. I said, well, yes, sir. I don't think I have anything to show. I'm not having any success. And then he says something that I'll never forget. He says, Jose, you need to understand you were sent there for one purpose, which is to learn to do research. None of us ever thought you were going to succeed on this project. We've been trying to do this for 30 years. We didn't think you'd pull it off in 2 months. And I'm like, what? He goes, the purpose of your mission was to learn about research and trial and tribulation and how challenging things are, not only in research, but in life. And then for you going out, remember that it's, there's a mission, and that's to serve your patients. You're going to have some challenges. So I listened to him loud and clear, and I said, okay, yes, sir, over, hung up, and went back to the bench and did what I could. He did tell me, make sure you photograph everything, because you are going to come back and present. Even if you have any data, we are going to hear what your hypothesis was, how you plan to do it, what you attempted to do, how did you address, how did you pivot at that moment to accomplish this, and that's what we want. So I went back, completed that, went back to Gorgas, and I'm going to read this letter from Thomas Aiken. So he says, Dear Jose, I have been meaning to write for some time, but the lab work keeps me very busy. I had hoped to hear good news, but was distressed to learn from Dr. Downs Friday that you were having a frustrating time trying to get anything accomplished. All I can say is that this is nothing new. And for those of us who have worked in the field, this has happened many times. Work can be relatively easy when it is done in the ambience of a first-class institution such as Yale Medical School, where everything is laid out or readily accessible, just like the capillary pulling machine. Remember, I told you to learn how to pull them by hand, as you may never have access to a machine again. I sympathize with you and your problems. If nothing else, it has been a great learning experience. I hope you will be able to work something out with the Gorgas people. I saw your car from Panama. It sounded as though you had an enjoyable experience. Good luck and keep the old chin up. Don't let this get you down. We're all rooting for you. We're all rooting for you when you're out there. Do not let the chin down. Remember Thomas Aiken. Keep the old chin up. I'm going to share another story, a little more surgical. This is during my surgical residency. And as Dr. White pointed out, I was lucky to go to a great program, as you have a great program here. And as I heard the description, it's very reminiscent. I will just tell you that a lot of my training that we got there was at the mothership. We had a phenomenal relationship with Summit in Summit, New Jersey, Overlook Hospital, where a lot of our great training was had there by great surgeons who had trained in different places, a lot of them at Columbia. But it was that combination of the mothership training as well as local community hospital. And I hear from your teachers here that are some in-house and some in the community setting. That's exactly the same program that we had. In a lot of independence, we were talking middle of the night. We were doing our own thing, sometimes supervised, sometimes not unsupervised. So that's me on the far right there. Thomas King was the program director, and the five in the middle, in the front row, are the chiefs of that year. Fast forward a year, and it's July 4th, 1984, and I'm 1 week old, second-year resident. So literally, I'm just finishing on my internship year. And I drew the short stick, and I was on call that weekend. And I get a call. I'm in my on-call room that a 65-year-old man had been stabbed in the chest a block away, and that the orthopedic team happened to be at McDonald's, swept them up. Someone had put an angiocath in the right, and they got some air. They intubated him and brought him right into the emergency room, and I got called. So I'm in there, and the man I'm on his right side, on his left side, head of the patient, legs. In front of me is his intern, Mike Chatham, who had, when I was an intern on the chest service, I had taught Michael Chatham, who happens to be now a prominent ophthalmologist in New York City, I taught him how to put a chest tube in. So as I'm watching this thing, I'm realizing I'm the most senior surgical present in that emergency room, which is probably what you have here. To my right is Heidi, a senior nurse of 22 plus years. A chief resident in medicine is putting an angiocath in the groin, and I see that it's bright red blood. Heidi's telling me no pulse, no pressure, no pulse, no pressure, and I'm thinking, and in those days it was right, I don't know what it's like now in the field, but it was quite controversial to do or not do an emergency room thoracotomy. This is before Trunke and Chip Baker wrote those articles that we all know about. Very debatable to do or not do it. I'm thinking, how do I defend this tomorrow? And Heidi's saying, no pulse, no pressure. So I said to my chest tube on the right, air comes out. She says, no pulse, no pressure. And I said, we've got to do a thoracotomy. And she's got the blade up already, the big blade. And the chest is early painted with betadine. I'm like, so I go through, open up, the pericardium, evacuate the blood, and it's fibrillating, it's not working. So I turned to her and said, we have to sap him, and she's got the paddles ready to go. So I'm figuring out quickly, my brain is figuring out, she knows what's going on here. Put the paddles in the heart, and she says to me, how much? And that's when everything stopped, because even though I will tell you, in June, my fellow residents, we were in the on-call room, we had one of those contemporary surgery booklets that had a beautiful description of how to do emergency room thoracotomy. We looked it over because we knew we were going to be in the hot seat come July. But it never described how much to put in the chest. And in those days, Columbia, in that neighborhood, Upper West Side, it was, and the New York Times called it the crack capital of the country. That's how much activity we had up there in the emergency room. So we had a thoracotomy very frequently, but I never had seen the paddles on the heart. So when she asked me, and at least in my brain, moving at super speed motion, what do I do? Do I guess a number? Do I say I don't know? And who do I turn to? No, there was only medical people there. Mike Chatham, as good as he was going to be an ophthalmologist, although I didn't know it at the time, but I wouldn't trust him. So what I said to her, and I've quizzed all my surgical fellows on this when they train that slum, I said, what would you say? And they all gave out crazy numbers. Sometimes it's right, but in a split second I said, the usual. And she says, you got it. Boom, saps it. The heart spank and sink. This thing is shooting up into the chest. Put my finger on it. I clear my throat. I'm like, call cardiac surgery. And they whisk this man up to the OR. I kind of navigate, levitate to my on-call room. I'm lying there. What happened? 15 minutes ago, I was down here, and then I get a call from the OR. They want me up there. Get up there, and the cardiac boys are up there, and the gals doing their thing. And they said, hey, are you the guy that did this? And I said, yes, sir. So look at that canister. You see all the blood in it? I said, yes. And I said, well, he lost more blood from your incision than he did actually from the repair of the heart. I said, I'm sorry. And I started walking out. And he goes, hey, you, José, Pepe, whatever your name is, get over here. Typical cardiac talk. Get over here. So I said, okay, yes, sir. He says, well, it's better to be lucky than smart. I said, yes, sir. He goes, well, because if you had made the right incision a little lower down, you wouldn't have damaged that much pectoralis. But you probably, on the other hand, wouldn't have saved his life because the injury was a little bit higher up. You wouldn't have seen it. So better lucky to be smart. He goes, now get out of here. So I go back to my call room the next day. The word of the town, the guy survived. Amazingly, and so I was feeling pretty good, and then I heard through the grapevine that Heidi was very, very upset, and no pulse, no pressure, I mentioned that, and she had gone to speak to Keith Riesma, another giant, I think there's a pattern here, Keith and cardiac surgery, right? This is the same thing. Keith Riesma, and as a great, as your colleagues and your mentors here, Keith was a transplant cardiac surgeon, chair of the program at the time. And this is exactly what he looked like, because when I Google him now, Wikipedia, that's the picture. It says Riesma 1984, writing after, that's exactly how he looked like. And he had an open door policy, and Heidi went to him. She was very upset, because what had happened, the third-year resident that had come down and whisked this man up to the OR, who apparently was not doing so well in the program, I later found out. And it was a parameter program at that time, so if you were not doing well, there were reasons you could be dismissed. Anyway, he decided to take credit for the thoracotomy. And Heidi, I was, unbeknownst to me, I was in a different planet at that time, but somehow Heidi didn't like it. She spoke to him, told him, and he was very upset about it. So he called me in. And you know, when the chair of surgery calls you in to your office, to his office or her office, as a second year resident, something's wrong. So I went up there, and he just very simply said, Jose, what happened the other night? Tell me what happened. So I told him, and I did not know there had been a conversation. And he says, well, good, now get out of here. So I went, and unfortunately, he did, as I was leaving, he said to me this, which I want you to keep in mind, is recognize expertise and trust those colleagues. And regardless of their rank, I can tell many, many, many stories about how, as an intern, I was considered really good a couple of times along the way because of listening to the nurses. I couldn't understand middle of the night phone calls. I'd go up and see them, and I found the pattern in my mind was the nurse can smell the problem. As you all know, this is for the junior and the medical students of any in the room. They can smell the problem. They may or may not know the physiology as well as you have by having had the privilege of a medical education. But between my medical education and totally not knowing anything about Gestalt feeling together, we picked up a lot of stuff and often got credit for that. So this is what this is about, is recognize expertise in all your colleagues, all the providers, trust them, and also be honest. Because I think the message of this unfortunate gentleman, he was let go. I think this is what broke the camel's back. They didn't assist him. He was not being honest. So recognize expertise and trust those colleagues and be honest. When I was at Columbia, this is Kenneth Ford. For those of you in the colorectal world might know of him. Fascinating man who in the 70s went to medical school at Columbia, graduated from the Columbia Surgical Program. He was the only person of color in both graduating medical school and in the Department of Surgery. Was thought to be quite good when he was retained, and his first appointment was at Harlem Hospital. And he wanted to really be at the mothership because of the quality and the level of research that was being done there. He tried to come back, and eventually, 5 years later, he came back. He had a full-time appointment. And I became great friends with him. He was a mentor of mine, and he taught me many things, including treat all with respect and courtesy. And what he figured out was that for his first 40 or so cases, there always seemed to be another young faculty, only 2 or 3 years above him, who was evaluating his progress during the procedure, was cross-examining him pretty much about the indications for the surgery, the approach for the surgery, and the postoperative care. And he always felt that that was a bit of a stress for him, and it was a bit of an imposition. But I think he was able to work with that, and as he pointed here, I learned early on that you have to know how not to accept denial of privilege or to get caught up in confrontation, nor blame, but find a way to get around it and overcome it. And I think that was a skill as a diplomat, phenomenal individual to rise as a trustee of Columbia University. And the presidents of the university would turn to him for advice because he had this ability to understand people. And I remember him walking through the main entrance of the hospital, and everyone got the good morning, and from Barbados had this beautiful accent, which just welcomed everybody with the same cordial, same respect, whether you were the dean, the CEO, or professor, Nobel laureate, or part of the support staff, even the parking attendants. I think that I will tell you that that's what made him special. But also was that his ability to persevere. And even the president of the University of Columbia would say that Ken Ford, here we are a couple of shots later on, and you can see my dear friend Ken, but he was known for his word of perseverance, my boy, my girl, perseverance. That's what he would have taught you. I think, and he just did it in a seamless manner. But deep inside, there was something about him that said, I'm going to make this work. And I think the best way to do it is to not be confrontational, but just adhere to what you think belongs to you, what's right and should be yours, and work with your colleagues. When he was at his celebration for retirement, just to reflect on how impressive he was and how impactful he was, they threw this, never to be repeated again, I think in the Rainbow Room, which is an iconic space in New York City, right above Rockefeller Center, to a Soul House attendance. Katie Couric spoke, because he's the man that did the colonoscopy on national television, on Katie Couric. He's the same gentleman. But to see the level of interaction with Ken and any other, regardless what your level of rank would be, but he was persevering. I'm going to tell you some experience that I had during my Columbia cancer research experiences. As was pointed out by Dr. White, I was really, really lucky to work with Bernie Weinstein wonderful man who taught me many things, one of which he said, Jose, the nicest people come from Madison, Wisconsin. I said, why is that, Bernie? He goes, because that's where I'm from. But I never called him Bernie. I forever would say Dr. Weinstein. He would say, Jose, it's Bernie. I said, yes, Dr. Weinstein, it's Bernie. But he says, that's surgical training. You can't seem to shake that, this whole hierarchical thing. But a mentor introduced me to cancer research, lifelong friend. And when I worked with him, he had several assays and several particles that were only available in his laboratory. And I, as a surgical resident, had access to tissues. So most of the things that the genes were being discovered, proto-oncogenes were being developed. And so I had an opportunity to look at this expression in cancers. And we found some things that were pretty exciting. So I was all ready to publish it and working on it. And Bernie comes up to me one day and he says, Jose, I've got some bad news. I said, what's that? He goes, well, we've been scooped. I said, what does that mean? He goes, well, somebody took our data and has published it. I said, how could that be? Well, one of my postdoc who's now in Boston on the faculty position published our work, and he goes, you gotta be careful because the science is easy, and as we've been hearing today, it's the politics that will kill you. So whether you're in clinical care, administrative care, research practice in the community, it's the politics that you have to be careful. Look over your shoulder, stay the road, the North Star for you, but just not everyone else may have the same philosophy. I just don't want you to be walking out there and be blindsided by things. Just be aware of that. Not to be too skeptical, but just recognize that. On the other side, I will tell you some of the positive side of the politics is that I was the first surgical resident ever to work with Dr. Weinstein because of my proximity in the buildings there. But because he had a wonderful relationship with the Japanese cancer associations, there was a school of surgical residents that came after me. And all of these have become like major prominent. The fellow with the enormous bouquet there was the president of the Japanese Surgical Association. These are all proteges of Bernie Weinstein's laboratories that have become surgical. And this is the 2018 Japanese Surgical Association. And we all worked on colon cancer, colon carcinogenesis. So that's a positive side of the politics that I would say. Here I am, exactly where you guys are right now, and gals. That's 1990, June. Are you done with your, do you have any more access to the OR, or you're done? You have no more cases? Well, make sure you go by the OR and get a picture or something, because you're gonna, these are, and to not be too graphic, I'll tell you later what the case, why my last case was, you'll never guess it. But that is the last case that I did as a surgical resident. And here I am, this is the last, I'm sure you're gonna get this kind of picture, it's just precious for me. My fellow chief residents and Dr. Reemsman in the middle. You see that picture looks exactly like the Wikipedia picture that I showed you earlier. Tom King. On the far left, that's a dear friend, Tier Wilbanks. We lost him a year or two ago, year and a half now, from multiple myeloma. He was a pediatric surgeon in prior practice in Greenwich, Connecticut. Next to him is Michael Marin, who's a prominent vascular surgeon, a chair of surgery at Mount Sinai. Next to him is John Chabot. John is an excellent hepatopancreability surgeon at Columbia. He's the chief of that division. Dr. Reeves and myself, and to my left is Tim Tudor, who is a renowned, probably the most recognized out of the whole group here. He's at UCSF, and he's the inventor and developer of all the sidearm stents. And I was just telling Dr. White last night about, at the time that I was in this super scientific laboratory with a luminary like Bernie Weinstein doing some real science, I thought real science, labeling all sorts of stuff. And Tim and I would be in the on-call room sometimes comparing notes, and I found Tim on the back of a napkin drawing some little things. I said, what are you doing, Tim? What is that you're doing there? And I felt pretty superior doing some basic science stuff, but Tim was drawing out, well later, he has patent. And I think for those in the vascular field, he's a prominent, he's won the Jacobson Award for the American College of Surgeons, quite an accomplishment. So my experience at Sloan Kettering, this is through my chair, Mary Brennan, which you've heard me mention today, a mentor, taught me the role of surgeon and leader in multidisciplinary cancer care, lifelong friend. Here's my team, several of them, and I will tell you, big collaborative group, international, over the years, I forget which surgical oncology meeting or wherever we're at, but Masaru Kurunami, who went back to Japan, Carol, he's from Japan, Carol Swallow from Canada, from Toronto, now she's the chair of surgery at Toronto, myself, Claudia Bellucco from Northern Italy, and Xiaoxi Zheng from Beijing. And at the time, what I learned from Murray were several things. I was lucky to get support to start off with 3-year commitment. Had a lab, we had several PhDs working in it, great publications, impactful journals, came this close to getting an R01 grant in this. And we kept going at it. At the same time, I had a growing family. I had 2 kids coming out. I established the Hereditary Colorectal Cancer Family Registry at Sloan, which took a lot of work. A booming practice. I was pretty good at rectal cancer surgery in particular. And there was this PET imaging leader who came from the NCI, Steve Larson, and he wanted to do a program project grant in different diseases, and I joined him, and we'd got an R01 in that. So that's when Dr. Brennan sort of laid it down to me, brought me into the room, and he said, Jose, you got a lot going on here. You got something's going to give, and him and Al Cohen, who was my chief at the time, sat me down in the room, and when you get another hint, the chair and your chief in the room at the same time, something big is coming down. And I was doing well, but the message was, we like you, Jose, we just don't want you to fail. You've got to trim it down. And Murray said to me, it's the Willie Sutton rule, Jose. And I don't know if any of you know the Willie Sutton rule. I didn't know it. I said, what does that mean? He goes, Willie Sutton, you got to go where the money's at. I said, what does that mean? He goes, well, you have an R01 grant in PET imaging, and you got this wet lab, which you're doing great stuff, but you don't have a grant in that. So and you got a practice, you got a family, and you got the registry, you better focus and just shut the lab down. And I just couldn't fathom that, because I had always been hanging out in the lab. It's like the movie, Apocalypse Now. You smell napalm in the spring. I kind of missed the lab smell. I really wanted to be in it. But he said, no, I think you should consider, within a year if you didn't get the R01. So the message from Murray to me is, like Willie Sutton, because Willie Sutton was a bank robber. So whenever he robbed the bank, he would get incarcerated. And then he'd get out, and he'd rob a bank, and they'd catch him, incarcerate him. And eventually somebody asked him once upon a time, why do you rob banks? And his answer was, because that's where the money's at. So Murray says, go where the money's at. So I gave up the lab and went on to do other things. I think I redefined myself in multiple different areas. I found enjoyment, collaborative science, team science, which is the modality most successful now for surgical people to participate in. This is some of the folks that I've worked with over the years. You recognize Mary Brennan there and Ken Ford, Tulukian, a pediatric surgeon, Richard Resnick, a big luminary in surgical education from Canada. So what Murray Brennan taught me was that change is inevitable, and it may be imposed upon you, pseudo-muscled onto me in a very parental, cordial manner, but it's inevitable, but reinvention is good. So I humbly suggest to you as you go out is to keep that in mind. Be nimble, be flexible, be creative. I think as Dr. White and I were talking about, this is good. This will keep you young. This is what Clint Eastwood will tell you. He's 95, and he's all about just keeping and reinventing yourself. And don't shy away from the challenges, but embrace the change. And the last one that I'll say is wrapping up is the timeless wisdom that I have learned from so many people. And I'm not quite the historian as Dr. White is, but I'm beginning to read more about it, and I find things, the 6 degrees of separation sometimes, and things that overlap in a nice way, and I'll share that with you. As pointed out by the young resident sharing the case, who I think is going to be a colorectal surgeon. I got to get your name, buddy, but we got your number. Unless anyone else cardiac futures for you, I will humbly suggest colorectal. Anyway, this is a man who, Lord Moynihan, first professor of surgery at Leeds University, and as I heard the discussion today, a lot of thoughts came up, but I first heard of him because when I started to develop the registry at Sloan Kettering on familial polyposis, one of the original ones is at St. Mark's Hospital, and when you dig deeply into it, besides Busey, who was a great pathologist and other people, it was the first clinical registry was this gentleman, Lord Moynihan. But he also founded, he did a bunch of firsts as well, like having gloves in the OR and scrubbing beforehand, wearing gowns. He did all of that stuff. I just, to minimize the slide, I deleted all that. But he founded this chirurgical club, which was interesting. The reason he did this is because at that time, the only perceived quality surgery was being done in London, and he was in Leeds. And there was this kind of disparity in perception that if you were not in London, you were not a good quality surgeon, sort of the community gown challenge. So he started this, and it's now one of the most prominent societies out there. And the idea was that these surgeons would travel from center to center, from hospital to hospital outside of London, and get quality care, learn from each other, and elevate the quality of care outside of London. So I think it was a phenomenal contribution. Also the creator of the Association of Surgeons in the British Journal of Surgery. But apropos to you, as I went and kept this man in mind over the years, ran into this saying, which I leave you. I want you all to be very cognizant, remembering of this line that I'll read for you, whether you're in practice, academia, administration, or research, that when you're the surgeon, and you're not in those spaces, but in the space that you're going to be operating in, you must have the heart of a lion and the hands of a healer, not the claws of a lion and the heart of a sheep, infinite gentleness, scrupulous care, light handling, and purposeful, effective, quiet movements, which are no more than a caress, are all necessary if an operation is to be the work of an artist and not merely a hewer of flesh. So I would remind you to please remember embryological planes, be gentle with the tissue. I can tell you my personal experience, the gentler you are, and I'm not talking about making minimally invasive incisions, that's part of the game, but also when you're in that cavity, it's how you handle that tissue. There's a relationship in my mind, and I'm sure there's data out there that shows the less retroperitoneal dissection we need, unless we have to do it, the better the patients are going to be doing. So please, first and foremost, it's the moment that you're holding that instrument, regardless of what that instrument is, that you are the captain of the ship, that you have an opportunity to do it the very best you possibly can, and you get better with time, right? So my takeaways are keep the old chin up, recognize expertise and trust those colleagues and be honest. Perseverance, perseverance. The science is easy, it's the politics that will kill you. Change is inevitable, reinvention is good. And the heart of a lion and the hands of a healer. I would be remiss to come to the Mecca here and not tell you about Dr. Griffin, my great friend back there, who's the reason I know you folks, is because I met him with Dr. Cole and others over the years in different surgical venues. But as you know, the double staple anastomosis, invented by the Russians, brought here by, it was Mark Ravitch and Steichman. Mark Ravitch, who was a pediatric surgeon at Hopkins, and Dr. Steichman, who was an esophageal head and neck surgeon up in New York City. They went to Russia and brought this instrumentation back here. But it was Dr. Griffin with Dr. Knight in 1980 who published this seminal paper that has illuminated a lot of surgeons, particularly in the surgical community. He's one of our Babe Ruth, Mickey Mantles, for those of you who may know those iconic members. And I was at the Southern Surgical just a couple of years ago and had the opportunity to meet Charles D. Knight Jr. And so here, delighted to have Dr. Griffith with us. In terms of the history, just to share this with you, because as I learned a little bit about yellow fever in preparation for this talk, I remember that Carlos Finley, a Cuban epidemiologist, first showed the association of the Aedes aegypti with the transmission of yellow fever. It was William Gorgas, the Surgeon General, who eradicated yellow fever from Panama, involved with the construction of the Panama Canal, and Franklin H. Martin. I want to have a show of hands from the surgical trainees. Does anybody know the name Franklin Martin? Good, even though the information's up there. I didn't know that either. I was just revealing this to Dr. White, that every year at the American College of Surgeons, one of the lectures that you will hear will be the Franklin Martin lecture. So now you'll know when you go there, when you go to the convocation, which we hope we'll see you there probably in a year or two, you'll hear the Franklin Martin lecture. But this is a giant involved with the college, started the journal, started the annual clinical congress, but he was also president of the Gorgas Memorial Institute. So I want to thank you again for your time and the honor to be here, and congratulate you, the graduates of this great program, and remember that you have many, many mentors here, and you'll have many stories that will help you as you go forward in your challenges. And I would say probably the best thing I can tell you is to be humble, to be strong, and remember that it's a learning process, but if you have your heart in the right place, you'll make the right decisions. Okay. So there's my email. You can reach out. Thank you.
Jose, thank you so much. Number one, just for being a friend of mine, and Dean, once again, to getting you here. But number two, just sharing this knowledge. This is knowledge for not just surgeons, but for everyone in life. So this is a memento, I should say, from LSU and from our department. So glad to have you here. And appreciate you seeing us.
Thank you so much. Appreciate it.
Good enough. Dr. Sitt, good to see you here. All right, I guess we're going to start with the awards. Once again, great lecture, great talk. Politics will kill you for sure. Louisiana, glad to have you here. All right, I'll leave it up to you.
All right. Well, this is now probably the best time for the Chiefs. Obviously, this is not the graduation, but this is where we give your plaques and your chairs or lamps, as some people have. But once again, I won't necessarily have this time for tonight at the graduation, but I want to just thank the Chiefs. Obviously, the care that y'all serve for our patient population and for us as faculty have been immeasurable, and thank you for making my first year as PD very easy and straightforward. So thank y'all for all that y'all do, and good luck. I know that y'all will make us proud and that y'all will do great things in the future. So without further ado, we'll go ahead and get started in handing out the plaques. The first is going to be Raquel Campbell.
Thank everyone for coming. Looking forward to our party tonight. It really is a party if you think about it. And so we'll see you at 6 o'clock at the Petroleum Club, and we'll give you a chance to speak. And we're really looking forward to this. Thanks for all you do. So there's going to be a subset of people, I think, that are going to come to lunch with me and Dr. Guillem. So we'll meet at Shreveport Steakhouse about 12:30. Okay. Thank you, everyone.